For joining us here, those who are here with us in person and those who are here with us virtually. I will tell you, this is my first in-person hearing in 3 years almost. About that, it's all the time's a little bit of blur here. So I'm just going to ask for your patience as we move along and we try to figure out how do we ensure that people continue to have greater access to the legislative process by joining us virtually, and then how we also pivot back and forth to those who are here in person. We're going to get this. It's going to be a great hearing, but just know that this is our first as well. So again, good morning to all of you. I'm so thrilled to be joined by my colleague and Senate co-chair Julian Cyr from the Cape and Islands. I'm Marjorie Decker, House Chair of Public Health from Cambridge. I want to welcome to the, we have a lot of members who are here today. I'll start with those who are sitting here with me. I have Representative Kasner. Thank you for joining us. Representative Garcia, great to see you. Over here, I have the ranking minority leader, Representative Kane, who is here with us. And a returning member, in addition to Representative Kane, is Representative Howard. Thank you to my colleagues who are here with us. And I think we have online Representative Irene Rosa. So I think he's online. At this time, I want to invite my co-chair to also invite his committee members.
Good morning, everyone. I think we have a number of senators who are with us in spirit this morning, and we're grateful for their participation.
Excellent. At this time, we will be hearing testimony on 34 bills pertaining to 3 topics: local boards of health, agencies, and disease prevention, screening, and treatment. These are all important bills that face each and every one of our communities, and I look forward to hearing from everyone who's joined us to testify today. I'd like you to be aware that we have more people signed up to testify than we had time. We've been fortunate to be able to, the hearing that was scheduled later today is no longer there, so we're not actually boxed into that hearing time, so we've been able to extend it. And we will try to get to as many folks as possible. We have allotted up to 30 minutes per bill because we want to make sure that every piece of legislation that's before us today has somebody who wants to testify. Know that there are a couple of bills that have a very large number of people, a lot of interest in those bills. And so if we hit that 30-minute mark on that bill, we will come back to you at the end of the hearing and try to get everyone else who has signed up so that you can also speak. If you think that somebody is saying what you would like them to say, and maybe you would like to just sit and submit written testimony, that is always welcomed as well. We, the chairs and our staff, always read the testimony that is submitted, and it is an important part of whether you deliver it in person or you submit it online. It is an integral part of how we also look at these the bills before us. Okay, I'd like to remind those of you that are joining us virtually, please keep your Teams app muted when you are not speaking. And to my colleagues who are here, I'm happy to recognize you if you have questions for the panelists. You also are welcome to follow up with any panelist if we don't get to you. Of course, committee staff is available for you as well. I'd also like to say thank you and recognize my vice chair, Representative Sally Kerins, who is with us today. And we didn't coordinate, but we do match. Okay, so for those testifying today, please limit your testimony to no more than 3 minutes, as we are trying to get through a large number of people who signed up. You will hear a gentle beep or a chime when your time is up, and then be muted if you are virtually, and we won't mute you literally here, but we will ask you to please respect the time of everyone else who's trying to speak. If you're on a panel, know that this committee has had a rule of no more than 6 minutes per panel. And that's really about trying to be fair to those who don't have the ability to be organized into a panel and come individually. I want to thank, of course, thank LIS, thank both of you for being here today with us. They have been through this, so we're relying on the experts down here from LIS to help us keep this hearing running smoothly. I also want to thank the incredible committee staff who have made this really seamless and ensuring that we can hear all of the voices of those who are here to testify today. Again, if you have any additional testimony that you would like to submit, please feel free to submit it. Legislators, as has been protocol, will be taken out of order. I will ask my legislative colleagues to remember, you can also call us as chairs, submit testimony, and we're happy to read that. And while you're not timed, I will ask you to please be mindful of the number of people in the community and the public who are also trying to testify today. And okay, I think the rest of it has been said, so we're just going to get started. Okay, the first bill here, I don't know if they still plan on doing this, but it is on, is correct. Here, Representative Kane, Representative Garlick, and Senator Comerford. I don't know if that was still. Okay, thank you. At this time, Senator Gomez, is he with us virtually or in person? Let's see him. Okay. Representative Dom. Senator Oliveira. Representative Doherty. And Senator O'Connor. Take us down here. Okay, at this time, we have a panel with legislators who've asked to come forward with their panels. Remember, if you're with non-legislators, we are keeping this panel to 6 minutes. So I would ask Senator Cronin, you were here on House 2177 and Senate 1349, an act relative to healthcare worker and first responder safety. And if you could introduce the members of your panel.
Respect to time, I will make some brief remarks, but I want to thank Chair Sear, Chair Decker, distinguished members of the committee for your consideration of this important bill this morning. In summary, it's a common sense measure that will allow frontline workers peace of mind that they need to carry out their duties to avoid costly and unnecessary treatments and to prevent serious illness. And I want to see the rest of my time with distinguished healthcare experts that we have joining us here this morning.
Wonderful. Thank you. Thank you for inviting me to speak with you today about this critical topic. I am Dr. Linz Franco. I have worked in healthcare since graduating high school, first as a nursing assistant, and then as a nurse for 5 years, and now as a doctor. I am a current 5th-year general surgery resident and critical care fellow at the Massachusetts General Hospital. I'm here today because it's so important to discuss the unintentional but significant harm incurred by healthcare workers because of our state law regarding HIV testing and consent. Healthcare workers frequently use needles and sharp objects to treat patients. Sometimes we accidentally get injured by these needles or sharp objects. This risk is increased when we are in critical situations in which we must act quickly with sharp objects in small spaces with many other members of the healthcare team to save a patient's life. Exposure to blood or body fluids can lead to the transmission of infections, such as HIV and hepatitis. In these situations, the standard protocol is to test the patient's blood for infections. In the case that the test is positive, the exposed healthcare worker takes medications to help reduce the risk of transmission of HIV. We're all grateful these medications exist. However, there are risks. These medications often cause nausea, vomiting, and diarrhea for the entire 28 days of treatment required. There are even more serious risks, such as liver failure, kidney failure, and potential birth defects that are devastating, particularly if a healthcare worker is pregnant in the first trimester. The current state law makes it illegal to test patients for HIV in the event that they are unable to consent. This happens all the time. Patients who are in a coma, who are unconscious, or who die cannot consent. Even if the family or the healthcare proxy would consent to testing, the state currently makes this illegal to test the patient. Massachusetts is only one of a handful of states that does not permit this testing. This means that every healthcare worker who suffers a needle stick or exposure from a patient who is unconscious, in a coma, or dies must take the prophylaxis medication. This is not without risk, and this is unacceptable. And this is because it is illegal to test this patient for HIV. I have spoken to many of my colleagues about this law, and one of them asked that I share her story. My co-resident, who is also a surgical resident at the Massachusetts General Hospital, was working in the emergency department. A patient came in who had suffered a significant motor vehicle accident. He no longer had a pulse. He was bleeding out and his heart had stopped. In order to save this patient's life, with a scalpel, she opened his chest, released blood around the heart, and clamped the aorta to preserve blood flow to the brain. When doing this, the patient's broken rib cut her hand. She was exposed. Even though the family members were at bedside, she was unable to test the patient. Unfortunately, this patient later died. And because of the state law, it was illegal to test this patient, even though the family had asked that the patient be tested. This introduced a tremendous burden to my co-resident. She and her husband had been trying to have a child for some time, and she thought she might be pregnant. So now, because this patient could not be tested because of the law, she had to take the medications to try to prevent a possible infection. This was a difficult decision because of the heavy emotional burden she had at the possible effects of causing a birth defect in her child. While taking the medication, she had continuous nausea, vomiting, and diarrhea while working 24 hours in the burn ICU caring for patients. She then had to delay her family planning an additional 4 months while she completed all of the testing required when a patient does not have a known HIV status. During this time, she also had emotional distress because she knew if she was intimate with her partner, she could potentially be a risk to them. As a surgical critical care fellow, I respond and care for patients every day who are unconscious, in a coma, or who are dying. I use sharps and other needles to save these patients' lives. It is a calling and an honor. However, under our current law, with the inability to test patients who are unconscious or who die, this is an unfair and unacceptable burden. This has even become a more heavy burden for myself as I have chose to have children. This is not a rare event or a rare occurrence. The current state law puts every healthcare worker, their unborn children, and their families at risk, and it is unacceptable. I'd now like to introduce my colleague, Dr. Elizabeth Connor, to speak on this issue as well.
Thank you for your testimony. If you haven't already.
Okay.
I'm going to add 10 seconds on, but you have just over a minute at this time left of this panel.
Okay, so my name is Elizabeth Connor, and I'm a resident physician in pathology at Massachusetts General Hospital. And thank you for allowing me to speak today. I just want to quickly emphasize that in pathology, we focus on diagnosis, and we do things like looking under the microscope to diagnose specimens. We do autopsies or we run laboratories, but predominantly we're affected when performing autopsies since a patient has passed away and we can no longer get proxy consent for HIV testing if someone is injured while that's happening. And so that's
Maybe just there.
so I just want to emphasize just a final thought here is that the Commonwealth of Massachusetts Department of Public Health has a clinical advisory that actually recommends violating state law because it puts healthcare workers' lives at risk. So thank you.
And if you're interested in that clinical advisory, I'm very happy to send it out.
Thank you. Feel free to submit any materials to the committee. At this time, are there any questions from any of the committee members? Senator?
So much for your testimony and your service. I just want to state, right, the reason, right, this law is in place, right, is because of the deep stigma that existed around HIV transmission, particularly related to heterosexual men, gay men, queer men, like myself, like many people serving here, right? So that this is sort of the history of how we got here. It may be time to sort of look at it in a different way, but just want to raise that up as sort of why the law is this way. In Massachusetts, we have among some of the strongest protections around HIV, informed consent, in part because of that really sad history. But just thank you for being here this morning and sharing your thoughts and experience.
And I appreciate that statement. I do have a significant concern and actually have co-residents who are members of the LGBTQ community. And they also worry that the current state law actually worsens the stigma that exists.
Thank you. They can submit testimony as well.
Thank you.
You.
Thank you. At this time, I want to recognize Representative Vargas and Representative Khan, who are members of the committee who have joined us online. And I know Senator Payano is also a member of the committee who's with us online. I would ask Representative Gentili to please come forward, House 2182, Senate 1330, an act to reduce incidence and death from pancreatic cancer. Welcome, Representative.
Thank you very much, Chair Decker, Chair Sear, and members of the Joint Committee. Thank you for taking me out of turn. I'm speaking today in strong support of my sponsored legislation, House 2182, which I jointly filed this session with Representative Hannah Kane and its Senate counterpart, Senate 1330, filed by Senator Joe Comerford, an act to reduce incidence and death from pancreatic cancer. Pancreatic cancer is an awful illness. The 5-year survival rate is only 10%. And over 70% of pancreatic cancer patients will die within the first year of diagnosis. This fact is a heartbreaking reality for the roughly 1,400 people that the American Cancer Society estimates will be diagnosed with pancreatic cancer in Massachusetts this year. I lost both of my parents to pancreatic cancer, so successful prevention and treatment matters a great deal to me, and also to Representative Kane, who is doing invaluable work as the chair of the Cancer Awareness Caucus. In August 2018, with overwhelming support from the House and Senate, Governor Baker signed into law a supplemental budget appropriation which created a special commission to study pancreatic cancer. The commission was charged with identifying areas of unmet need in cancer prevention, diagnosis, treatment, as well as providing recommendations for additional legislation and support to meet those needs. The commission was comprised of the Undersecretary of Health and Human Services and a diverse panel of agency leadership, survivors, and others. In October 2019, the commission published its final report with recommendations. This legislation seeks to implement those recommendations. First, to establish a comprehensive pancreatic cancer initiative to provide coordinated cancer prevention, screening, and education, and support programs. Second, the establishment of a 13-member pancreatic cancer advisory council of experts within DPH to develop and implement a statewide public education and community outreach program to inform the public about genetic risks, signs, symptoms, and pre-malignant conditions associated with pancreatic cancer, including new onset diabetes and the availability of clinical trials for those with pancreatic cancer. Third, a survey of health insurers to ascertain coverage benefits of genetic testing. These bills have over 80 co-sponsors and received favorable report from the committee last session. I strongly urge the committee to do so again, and thank you very much for taking my testimony this morning.
Thank you. This time I welcome Representative Driscoll to come forward on page 2156 and act relative to enhancing statewide hospital capacity coordination. Okay, if he's not here now, he can come back later. We have also testifying online. The next bill that we will hear is House 3622, Senate 515, an act relative to protecting public health and reducing healthcare costs. I'll start with Lisa, and I'm sorry if I'm not saying this correctly, Nagy, who is from the Environmental Health Center of Martha's Vineyard. Dr. Nagy with us? Okay, we will come back. We can. The first panel is Tim Cronin for Healthcare Without Harm and Paul Lipke, President of Room to Maneuver. And just keep in mind that you have 6 minutes in total, so be mindful of each other's time.
Thank you. Can you hear me fine?
We can hear you.
Great, thank you. Thank you to Chair Sear, Chair Decker, and the members of the committee. My name is Tim Cronin, Massachusetts Director for Climate Policy with Healthcare Without Harm, a local nonprofit. I'm here to testify in support of H 3622 and S 515, as you mentioned. Want to thank the leadership of yourself, Representative Decker, as well as Representative Dom, Senator Lewis, and Comerford, as well as the Conference of Boston Teaching Hospitals and numerous other healthcare stakeholders, hospitals, and community groups for making this legislation possible. This legislation tackles challenges at the intersection of our changing climate, energy use, and community health. Put simply, we need more data and better tools to achieve health equity and environmental justice, and to reduce the air pollution we've seen in every single town and city and community in the Commonwealth. This legislation provides just such a tool, as the speakers after me will outline, and I'm sure other panels will as well. In my testimony, written testimony, I'll go into a little bit more detail about how this legislation is connected to and really supports the 2021 Roadmap Climate Law and last year's Drive Act that was passed with the support of members of this committee and others, as well as the Healy-Driscoll administration's larger goals of working on solutions to the climate crisis across departments from multiple angles, including, importantly, health. Now I'll just turn this over to Paul Lipke, the real expert on this bill, who can provide a little bit more details about the tool and how it can benefit and advance climate smart healthcare. Thank you.
Thanks very much. Can you hear me okay?
We can.
Okay. So I'm with Paul Lipke with Room to Maneuver, formerly with Healthcare Without Harm, where I worked with hospitals statewide and nationwide, and I conceived of and led the building of a free web-based energy health impact calculator. So I want to thank the chairs of the committee for your leadership. And again, just iterate that this is an opportunity with Representative Dom Decker's House 3622 and Jason Lewis's, Senator Lewis's S515 to really help policymakers address energy emissions harm to public health or economy, and especially to drive healthcare cost containment. So I again urge the committee, as they have in previous sessions, to support this bill. These bills create an energy health assessment calculator to quantify the negative health impacts and healthcare costs resulting from delivered fossil fuels and electricity use, and the benefits of energy conservation and renewable energy. The tool will help policymakers and agencies understand the health implications and costs of emissions influencing decisions and ensure they are factored into policies, regulations, and programs with special attention to impacts on environmental justice communities, mass health, and community hospitals. Users simply input the energy consumed and the location, and based on the emissions, the tool will estimate the number of resulting health incidents and the economic value with respect to premature deaths, hospital admissions, respiratory problems, non-fatal heart attacks, work loss and restricted work days, mercury-related health incidents, and more. It can also normalize the health incidents and economic value per kilowatt hour or per BTU and adjust it for a patient day, hospital beds, etc. I'll close with just a couple of comments. You can buy a lot of clean energy for the cost of a trip to the emergency room for an asthma crisis or a respiratory crisis. The average Massachusetts household spends 6 to 10 times on health insurance and health care than what they spend on energy. By reporting out these bills favorably, you can help stop this fiscally irresponsible, if inadvertent, policy of shifting costs from energy to healthcare. You can help align and leverage efforts across departments, agencies, and the executive branch. Our tool was built based on US EPA, Department of Energy, and peer-reviewed data. It was built by Massachusetts firms who do similar work for the EPA. It is endorsed by the American Public Health Association and used by Boston Green Ribbon Commission's Healthcare Working Group and health organizations nationwide. So the Commonwealth can easily build on this essentially local tool with national implications if you'll please report these bills out favorably. So you have the opportunity to save our citizens thousands of health incidents and avoid hundreds of millions of dollars in societal health impacts. Thank you. I exceeded the rest of my time.
Thank you. At this time, I would ask Araliz Barboza. Okay. Mary Germanis. Okay. Do we have Dr. Greg Fury and Jonathan Slutzman?
Yep.
Okay, just you have signed up together, so just keep in mind you have a total of 6 minutes. So just be mindful of the follow-up panelist.
Great. Thank you to the Chair Decker and Chair Sear and members of the committee for the opportunity to testify and support House Bill H3622 and Senate Bill S515, Act Protecting Public Health and Reducing Healthcare Costs. My name is Dr. Greg Fury, and I'm joined by my colleague, Dr. Jonathan Slutzman. I'm a primary care physician at Brigham and Women's Hospital in Boston, where I also serve as the medical director for climate and sustainability. In this role, I work to prepare clinicians to address current and emerging health threats from climate change and to reduce the environmental impact of clinical care. It's with that perspective that I support this legislation that takes a critical first step to addressing the long ignored externalized costs of fossil fuel combustion on human health. For those of us on the front lines of healthcare, connections between human health, fossil fuel combustion, and climate change are all too apparent. The effects are already being felt right here in Massachusetts. In my own practice, I care for climate refugees, such as a patient who fled Puerto Rico when prolonged power outages after Hurricane Maria prevented him from receiving dialysis. I recently made my earliest diagnosis of Lyme disease, which has a longer active season due to rising temperatures. My patients' allergy symptoms begin earlier in the spring and last later into the fall. My elderly patients, appropriately fearful of the risks of extreme heat, are confined to their homes more and more. And I can't help but wonder how many of my patients' asthma flares, heart attacks, and strokes could be avoided if we collectively agreed that it's unacceptable, irrational, immoral to continue causing death and disease by burning fossil fuels when ample supplies of clean energy exist. Extreme weather events, which are increasing in frequency due to climate change, are already disrupting provision of essential care to patients. At my own institution, extreme heat and cold, also thought to be a consequence of climate change, and last year's drought have affected patient care. As I'm sure many of you are aware, one of our local hospitals, Norwood Hospital, closed due to severe flooding and had to be demolished and rebuilt from the ground up. A recent study demonstrated that many Massachusetts hospitals are at risk of flooding even from a Category 2 hurricane. It's increasingly clear that none of us are immune. Our Commonwealth is vulnerable to the health effects of climate change, although unfairly some, in particular communities of color, more so than others. We expect these health impacts to only worsen in the coming decades. Policy solutions that protect people from the health effects of climate change are a moral imperative. But as a practicing physician who feels the strain of an overburdened health system on a daily basis, I can confidently say that they're an economic imperative as well. With healthcare costs soaring and a workforce pushed to the brink, we simply cannot continue to ask the health sector to absorb the profound and avoidable cost of fossil fuel pollution and climate change on human health. In healthcare, we often say that prevention is the best medicine. Preventing death and disease from air pollution and climate change requires a policy solution, not a medical intervention. You all have the opportunity to potentially save more lives than my colleagues and I ever will. This bill is aligned with recommendations of health professionals such as the WHO and local public health professionals. By passing this bill, Massachusetts can demonstrate its commitment to protecting public health and reducing the negative health impacts of climate change. Thank you.
Are you joined by Jonathan Slutzman? Is he here?
Yes, I am.
Okay. You have just 2.5 minutes at this time.
Thank you, Chairperson.
Thank you.
Thank you. My name's Dr. Jonathan Slutzman, and I am the Director of the Center for the Environment and Health and the Medical Director for Environmental Sustainability at the Massachusetts General Hospital. I also practice clinically as an attending emergency physician at the MGH, most recently even just last night. I echo my colleague Dr. Fury's experience with patients' worsened clinical conditions due to climate change. As an emergency physician, I see patients in our crowded spaces night after night, limiting our ability to care for our Commonwealth's most vulnerable patients. Seeing more patients because of asthma exacerbations or increased incidence of Lyme disease or any of the other conditions that we face that we know are worsened by climate change only makes everyone's care worse and harder to handle. Beyond that, the Energy Health Assessment Policy tool created by this law provides valuable data that can inform climate-smart actions by a range of stakeholders, from public health policymakers to clinicians like myself and health facilities and community leaders. These and other stakeholders can use this tool to prioritize public health and reduce the negative impacts of fossil fuel use on their communities. For example, we at MGH have used environmental impact modeling data coupled with clinical effectiveness and safety data to inform our medical device purchasing decisions. This additional tool can contribute to decision-making about energy procurement throughout the healthcare industry and beyond. By avoiding the inadvertent shifting of public health cost burdens from energy to healthcare, this bill will help to ensure that resources are used more efficiently and effectively. By placing a quantifiable measure on the health impacts of climate change, the bill will help encourage investments in energy efficiency and renewable energy and can reduce the need for expensive healthcare interventions. Additionally, this bill has the potential to reduce the disproportionate health inequities that historically marginalized communities have faced due to health impacts of pollution and climate change from fossil fuel combustion. Finally, by reducing the negative health impacts of fossil fuel energy, this bill can contribute to alleviating stress on the healthcare system especially during public health crises like the one we saw during the COVID-19 pandemic, and the one that I see every day in our emergency departments across the Commonwealth. I look forward to including more information within my written testimony that I will share with the committee. Thank you again for the opportunity to testify in support of this legislation.
Thank you. At this time, I have David Seitz. David, are you on? Daniel. Okay. Daniel, hi, welcome. You're muted. All right, you're still muted, Daniel.
Yeah, okay. Now can you hear me?
Okay.
Great, sorry for that. First of all, thank you to the co-chairs and the committee for an opportunity to testify regarding this bill. I'm actually just going to be offering a few cautionary notes about the bill. I think no one would disagree with the idea that reasonable efforts to lessen pollution and conserve energy will help support the health of individuals. And we know that huge strides have been made in these areas over the decades. For quite a while, petrochemicals have been steadily denigrated and attacked as a component of our energy infrastructure. However, a too rapid transition to so-called renewables has its own set of potential adverse impacts on health, since there's not yet a sufficient infrastructure in place. For example, spiraling costs associated with switching to electricity may actually cause economic hardship that will translate into adverse impacts on health, as some people may have to choose between heating and cooling their houses, buying food, and paying rent or mortgage costs. In my own case, our oil for heat nearly doubled this past year. Luckily, I can afford that, but not everyone is in a position like mine that they can absorb such major costs. Similarly, a growing reliance on a vulnerable energy grid to meet a large share of our energy needs could lead to extensive interruptions in energy development delivery that could too have major adverse impacts on health. One was mentioned just a couple moments earlier, the energy grid in Puerto Rico crashing and causing a lack of access to dialysis services. Finally, I would like to say that renewables have pollution issues associated with their production, and these are often ignored in conversations about the various benefits and drawbacks of energy in relation to pollution. So finally, I'd like to say that my concern about a bill like this is that it has too narrow and potentially an ideological focus, and would not therefore look into the benefits to society of a robust multi-source energy system, one where we invest in the good pollution control and conservation, and that we need a resilient system in order to support good public health. Thank you very much for this opportunity.
Thank you. At this time, I would welcome Patricia Tobin. Okay. Patricia?
Yes, hi.
Oh, great. Welcome.
Yes, I may have inadvertently signed up for this bill, but what I will say is my comments are uniform.
Patricia, before you speak, Patricia, I just want to make sure if you've signed up for another bill, you won't have another bite at the apple here. So you have 3 minutes, and should all the bills that you thought you were signed up for.
I'll defer to the next one. Thank
okay,
you.
Somebody on staff needs to find out which bill it is online. Thank you. I would ask Laura Germanis. Lara, are you with us?
I think she.
That's okay. Thank you. Perry Evans. Okay. And then finally, we will ask Derek Neal from the Cambridge Health Alliance, the director of the Board of Public Health. Okay, he knows how to reach me. I would say if there's anyone else on House 3622, Senate 515 that has signed up and has not been called, now's the time to either raise your hand on the Teams or in the room, raise your hand. Okay, that is what we have for testimony today. Thank you to everybody who gave testimony, and please do feel free to submit your testimony in writing. It's also very helpful in addition to the notes we're taking on your testimony. At this time, I would like to recognize Representative Carol Doherty, who's here with us. If you are here on, thank you. Thanks for your patience.
Thank you very much. Good morning, and thank you very much to the chairs and to the members of the committee for this opportunity to testify to House 2551 proffered by Representative Phillips and its companion S 1450 by Senator Jake Oliveira. It is an act calling for a study to examine current access to essential health services as defined by the Department of Public Health, provided by the Commonwealth's acute care hospitals and inpatient psychiatric hospitals. The effect of discontinuing these services, the projected need for the services, and the study, we hope, will provide recommendations as to how to ensure access to these services in the future. That said, I would like to turn my attention to my own experience, the effect of closures on a community hospital in a gateway city, the city of Taunton. In 2011, Morton Hospital was privatized. With the promise of improving services and modernizing facilities, the community embraced the change. Shortly thereafter, in 2013, the pediatric unit was closed. In 2017, maternity was closed. After all, no maternity, no babies born in Taunton, no need for lots of pediatrics. Women and families since have traveled to surrounding hospitals to have their babies and to provide medical care for their children. The last pediatrician in town retired 3 years ago. Currently, there is only one OB/GYN person in the city, down from 3, with limited services available for maternal health provided by Manet Health. H2551 and S1450 will play a vital role in measuring the impact of what I have just described. As a result, data derived from the proposed study will lend itself to ensuring that essential health services for all residents of the state will be provided, particularly in underserved areas. The need for access to quality health care has never been more apparent. Compounding that history, a study will reveal, with the present crisis in staffing, funding, mental and behavioral health needs, may also serve to forestall further consolidation and closures of hospitals and essential services. Massachusetts has led the nation with healthcare reform. Our system of healthcare innovation, our hospitals heretofore have been the envy of the world. Sadly, though, for far too many, access to healthcare remains elusive. This bill is the first step in identifying gaps in access and to providing a roadmap leading toward rectifying inequalities. By identifying essential services that might be vulnerable to discontinuation, the study will help policymakers, us, take the necessary steps to protect health and well-being of our communities. I ask you to report H2551 and S1450 with a favorable recommendation. I thank you for your time and your consideration.
Thank you, Representative. At this time, we're going to move on to House 2251, Senate 1450, an act assessing healthcare access. I would just remind my colleagues who are on the committee, if you have questions, and I haven't asked you if you have one, you always have the right to just grab my attention. If you're online, do the hand gesture. I assume the last one, if you had questions, you would just come ask me since I filed that. But just please feel free to jump in. At this time, I'm going to welcome Professor Alan Sager from the BU School of Public Health. Welcome.
Thank you. Good morning. Here are 5 quick points, please. No accountability. No one in our state is accountable for identifying needed hospitals or emergency rooms or for paying them adequately. No one has a list of which care is needed. 2, big changes in hospital care. In 1960, we had 141 hospitals, 60 today, 60. The share of beds in big teaching hospitals was 18% in 1960, over 40% today. 3/5 of all revenue goes to 14 big teaching hospitals. Point 3, cost. Spending on hospital care is almost 50% above the US average. All health spending here was 31% above the US average. Total spending, $129 billion this year. We would save $30 billion this year alone if we spent at the national average, which is plenty. Point 4, high cost harms access. Why do costs matter to this bill? One, because many hospitals are financially starved. Second, our state relies on ineffective cost controls like boosting deductibles, copays, coinsurance. These payments hit lower and middle income people hard, and they don't contain cost. Higher patient payments and threats to mass health will undermine many needed hospitals in the future as they have in the past. Fourth, concentrating more care in fewer places means longer emergency room travel times and waiting times for all patients. Well, why this bill? This bill would assess which hospitals are needed to assure access. Sadly, in healthcare today, no one is accountable for anything that happens outside the building where they work. Well, why not? First, because we don't have a functioning competitive free market. Too bad, can't get it, not possible. Second, because government action in healthcare, federal or state, has rarely been comprehensive, continuous, or competent. Without a market, without competent government, US healthcare suffers anarchy. And anarchy is why the US spends double the rich democracy average while giving much less care to fewer people who die younger. Now, Massachusetts insures almost everyone who lives here, but cost controls are feeble. Enacting the legislation before you now would take a substantial step toward countering anarchy and in pointing our state toward durably affordable medical security that's accessible for everyone. Thank you very much.
Thank you. At this time, I'm going to welcome a panel from the Mass Nurses Association. There's 3 of you on the panel, so I just want to remind you that you have a total of 6 minutes having signed up as a panel, so be mindful of each other's times. Want to welcome Katie Murphy, Jennifer Goki, and Mary Havlicek Kornakia. If I didn't say that correctly, correct me. Welcome.
Actually, good morning and thank you, Chair Sear and Chair Decker and the Joint Committee for the opportunity to offer testimony today in support of Senate 1450 and House 2551. My name is Katie Murphy. I'm an ICU nurse at the Brigham and Women's Hospital and president of the Massachusetts Nurses Association, representing over 25,000 nurses and healthcare professionals across the state. Since being elected president, I've spent many hours and logged many miles driving across the state to facilities and units that are slated for closures. I visit these communities and talk with the nursing staff and the patients, and I hear the same things over and over again. Why are we losing these maternity services? Why are they closing our emergency departments? These service losses often affect our most vulnerable population, and when I'm asked how do we ensure these patients are able to access the care they need, I often don't have an answer. That's what brings me here today. Senate 1450 and House 2551 called for comprehensive data collection, including reviewing how these closures have affected access to essential health services, what access looked like for patients following closures, and how it followed or diverged from the plans provided to the Department of Public Health. Currently, we lack any understanding of the impact of recent closures on the communities they served and what that means for the future health and safety of the community. These bills would also examine current service capacity in each region of the state and calculate projected need in the coming decade, as well as looking what services are most vulnerable to closure or discontinuation in the near future. I want to give my partners a chance to testify, so I just urge that you report these bills favorably out of committee. Thank you.
Good morning. Thank you for the opportunity to offer testimony in support of these bills. My name is Mary Havlicek Kornakia. I am a nurse at Tufts Medical Center, one of over 1,400 nurses providing direct care at Tufts. I also sit on the board of directors at the M&A. On January 20th, 2022, the staff at Tufts Medical were informed that the Tufts Children's Hospital, which had operated since 1894, would be closing. This announcement sent shockwaves through our hospital community and the greater Boston community. Leadership at the hospital attributed the closure to a downward trend in the census, but this was coming off of 2 years of COVID, when a temporary decrease was seen across many children's inpatient beds. Despite community outcry and opposition from the doctors and nurses who staffed the hospital, it was closed at the end of June 2022. By late summer, a nationwide RSV outbreak had hit Boston area hospitals hard. We started seeing headlines about not enough pediatric beds for those sick babies. Children had to be sent out of state to receive care just 3 months after Tufts closed their pediatric beds. I can assure you that whatever you read in the newspapers, the situation inside the hospitals was much worse. This should not have happened. Our patients, our children deserve better. This was not something that should have caught us off guard. We do not currently approach hospital closures and capacity in a thoughtful, measured way. This data and information called for in this study would be a good step towards getting our arms around what our current capacity is versus what is needed to care for the people of Massachusetts. It would identify areas with healthcare specialty deserts and shine a light on the inequities and potential dangers that arise from healthcare access challenges. As early as 2017, the Journal of the American Medical Association Pediatrics had looked at pediatric services in Massachusetts and concluded, and I quote, "Pediatric hospital care is becoming increasingly concentrated, which should be accounted for in public health activities, disaster planning, and determination of network adequacy." But we didn't, and they were not. Now is our chance to act and take the first step towards addressing and understanding this problem, which is much broader than just pediatric services. Without the information called for in Bills 1450 and 2251, we will continue to take a piecemeal approach to access instead of a comprehensive statewide one. But with it, we can make more informed choices that better serve my patients and your constituents. It's nearly a year after the closure of the Tufts Hospital for Children, and patients are still having trouble navigating the system. Thank you.
Good morning. My name's Jennifer Goki, and I work at Anna Jake's Hospital in Newburyport, and I've been a nurse there for 12 years. Like Tufts Medical Center in 2021, my hospital chose to eliminate inpatient pediatric services, but unlike Tufts, the news at my hospital didn't make the front page of the Boston Globe. And if you don't live in the North Shore, you probably don't know that my hospital closed pediatric services. In fact, many members of our community didn't know that pediatric services were closed until they brought their children or grandchildren to Anna Jake's Hospital for care. The Department of Public Health said maintaining these pediatric services was necessary for access in our community, but they were closed anyway, and over the objections
I'm going to remind those, if you've given testimony and you're still online, if you could please sign out. You can go onto the website for the Massachusetts Legislature and still watch us. You can still watch us live stream. But if you've already testified, please log out. We find that having too many people logged on sometimes interferes with the quality of streaming. Okay. I would just say that please ask to submit testimony from all three of you, and we thank you for your time. All right. At this time, I think I see Senator O'Connor who's joined us. I called you earlier, I believe. Well, you can just tell me which bill you'd like to come talk on. Okay. Are you alone?
No.
Okay, so I would just ask that, given that we give electeds unlimited time with the panel, if you could try to keep it to 6 minutes between all three of you. Thanks.
Thank you, Chair Decker, Chair Sear, and to the entire committee. I also served on this committee, one of the 18 that we're on this year. So I wanted to thank you for the work that you're doing as you're kicking off this Very long legislative session that we have in front of us, as well as all the bills before the committee. I'm here to speak in support of Senate Bill 1442, which is an act to establish a special commission to find the best practices to promote education, awareness, and prevention of Lyme disease and other tick-borne illnesses. I'm joined today by Dr. Isabel Ronai, a postdoctoral fellow and American Australian Association scholar at Harvard University, who has dedicated her academic career to investigating ticks and tick-borne diseases. Massachusetts is a nationwide hotspot for tick-borne diseases and tick-borne illnesses such as Lyme disease, babesiosis, anaplasmosis, and Powassan encephalitis impact thousands of Massachusetts residents annually. Lyme disease, the most prevalent of tick-borne diseases, is known to cause flu-like symptoms, muscle weakness, and painful rashes. This disease often goes undiagnosed and misdiagnosed, prolonging patient suffering. And while illness lasts roughly 2 weeks with treatment, patients often suffer side effects that last 6 months or longer. The threat of tick-borne disease is not going away. In fact, Massachusetts has seen one of the fastest growing increases of tick-borne diseases in the nation over the past 30 years. In my opinion, it's our duty as a legislature to act. We did so about 12 years ago when we passed a bill to create a special commission then, and a lot of the recommendations that are in that commission have either A, not been implemented, or B, have just changed drastically due to the changing times that we live in. This bill would establish this commission, bring together these field experts, legislators, public health officials, and charge them with leading the way in identifying the best practices for increasing Lyme disease awareness, combating its harmful spread, and assisting those suffering from its long-term effects. I respectfully urge that Senate Bill 1442 be voted favorably by this committee so the Commonwealth can once again provide the legislature with the best solutions to address the growing threat of Lyme disease and other evolving tick-borne illnesses. And with that, I would pass it over to Dr. Ronai.
Thank you, Senator. Chairs and committee, did you know that May is Lyme Disease Awareness Month? There are over 500,000 cases of Lyme disease in the United States every single year. However, the current maps of Lyme disease cases from the CDC show almost no cases in Massachusetts. That is because there's been inadequate resources at the state level. What we do know is that over the past 2 decades, there's been a tripling of Lyme disease cases, particularly in the New England hotspot. For Lyme disease, early diagnosis and timely treatment is crucial, but the bullseye rash, often associated with this disease, is not always present, and many people are not even aware that they've been bitten by a tick. Education, awareness, and prevention about Lyme disease in Massachusetts is urgently required. I also wanted to tell you that Lyme disease is not the only tick-associated disease that you should be concerned about in Massachusetts. Massachusetts has the dubious honor of being the first in the country for cases of the viral tick-associated disease called Powassan encephalitis. This disease has a 15% fatality rate. Massachusetts also has the dubious honor of being second in the country for the cases of malaria-like babesiosis. This disease has been referred to as Nantucket fever because it was first identified in the United States in Massachusetts. But when I speak with residents here in the state about this disease, often people aren't even aware that this disease exists in Massachusetts. The senator had to ask me how to pronounce this disease. There are also the tick-associated diseases that we do not even know anything about. Over the past 2 decades, there's been 7 new disease-causing agents transmitted by ticks identified by the CDC. This is worrying. But what I find most concerning is that we now have reports of ticks being what we call co-infected. Sometimes ticks are carrying 5 disease-causing agents all at the same time. From such tick bites, Massachusetts residents who I've spoken to have had their lives changed forever. Tick-associated diseases have a huge impact on the state economy through loss of productivity and cost of healthcare. But we tragically don't even know what the health impact and economic cost is at the state level. What I do know is that a single tick-associated disease, Lyme disease, is estimated to cost the US billions of dollars a year. I also wanted to highlight to you that the federal government's recent publication titled The National Inventory of Tick-Borne Diseases and Associated Illnesses, this report unfortunately shows Massachusetts is an outlier because states with high incidence of tick-associated diseases normally fund activities and research to combat them. For example, Pennsylvania spends $3 million a year combating these diseases. A bill on tick-associated diseases, education and awareness and prevention in Massachusetts is desperately needed. I'm speaking on behalf of the thousands of people in Massachusetts whose lives have forever been changed by a tick-associated disease and urging you to report this bill out favorably. Thank you.
I would just say, as someone who grew up in the Outer Cape and spends much time in the National Seashore, tick checks are always something in my family, and Cape Codders and Islanders really take quite seriously. And so I want to encourage folks who are listening today to really do those tick checks when you're out. When you're out and about, it's getting to be a beautiful time of year to be outside. But those tick checks are very important because when you look for them, you're going to find them. So thank you for testifying.
Thank you.
Thank you, Senator.
Thank you.
Thank you.
Thanks, committee.
At this time, I have Representative Driscoll who has signed up to give testimony.
Thank you, Chair Decker. Can you hear me okay?
I can hear you.
Great, thank you. Thank you, Chair. Thank you, Chair Sear, members of the committee. Wanted to testify before you today. I will certainly submit written testimony as well, but I wanted to introduce Bill H2156, which is an act relative to enhancing statewide hospital capacity coordination, also known as a bed board. So I know that many of you are aware of just the incredible work that was done throughout the multiple surges during COVID-19, the height of the COVID-19 pandemic. The work that was done by professionals in the healthcare space, particularly at hospitals, with emergency medical services doing transport, to basically what's referred to as patient load balance, based upon the staffing, availability of beds to treat patients, whether it was COVID or some other ailment. And it was really the work that's been done over the past 3+ years was really a bright spot, so to speak, throughout the pandemic in terms of the collaboration that happened across the healthcare space to make sure that people got the care that they needed in a really timely fashion, and that ultimately no one hospital was too overtaxed for for very long because of this regional collaboration that occurred. A lot of this was done over conference calls, over text messages, over WhatsApp, different platforms. Calls happened at times weekly, sometimes daily. And it's not just the pandemic where we've seen this. If you remember last fall, the surge in RSV and flu earlier than anticipated caused a real stress on hospital capacity. And again, this has been done really successfully. What this bill seeks to do is compel Department of Public Health to set up a group to create a platform for this quote unquote bed board, so that there would, at the end of this, ultimately what we hope exists is a technology platform where there's data being fed in from hospitals across the state that can then be utilized to facilitate this type of patient load balancing in the future among hospitals, and also give kind of a thermometer, so to speak, a gauge on if there are certain regions or certain healthcare facilities in the state that are seeing a surge or kind of an overburdening of patients coming in. And so basically an early warning system that there may need to be this type of coordination stood up. So it's not necessarily something that will be on every day and visible to everyone in the healthcare space, but as long as that data is being collected on capacity and capability at hospitals, it'll give us an early warning. And then if we have a mass casualty incident or some other surge, it'll be there to help facilitate, safe care for folks. So that's in it in a nutshell. I'm happy to answer questions now or at a different time for the committee, and really appreciate the opportunity to speak today.
Thank you. Happy to take your written testimony. And if anyone has questions now or would like to speak to the representative directly, you can do that as well later. Thank you.
Thanks.
At this time, I'm going to invite a panel on Senate 1447, an act relative to healthier, stronger Massachusetts. And I have 4 people on this panel. To keep in mind, you have a total of 6 minutes, and to be mindful of each other. Paul Kearney, Steve Flamos, Rick Langella, and Kim Trapello.
Yes, good morning. Am I on here? Hello? Hello?
Hi, you're on. We're listening.
Oh, great. Thank you. Thank you for this time. I am speaking for my constituents that are in the fitness business, Steve Trapello, Kim Trapello, Steve Lemieux, and Rick Langella as well. This is a joint statement. First and foremost, we want to thank you for your time and commitment to the Commonwealth. We also want to recognize that 1447 would save lives, save time, and save money. This has been an epidemic during the pandemic for not only the increase in loneliness, depression, mental health, physical health. This bill would help not only to minimize the effect of the pandemic, but it'll also help Massachusetts in its future. The idea that fitness fitness clubs have been closing all around the Commonwealth, as you guys probably know in your constituents, and I know you've heard of fitness clubs closing. Over 30% of gyms have closed. Most of them are small business owners that have went through some huge financial liabilities, as well as depression, like I said, for our folks that are joining our gyms. We're starting to see people slowly come back, thank God. However, this bill would not only save time, save lives, and save money, it would also help small businesses keep their motivated staff. Every dollar you spend in physical fitness, you get $5 back in productivity. You have less absenteeism, better productive staff. There's a whole host of things that are positive about this bill. So we would ask that you take some time to visit your constituents that have local gyms and understand the fact that 30% of them have been closed, but also 50% of people that have worked in a gym lost their jobs. So a lot of the fitness classes have gone. A lot of the seniors are not coming back because they're afraid to. We're slowly making some progress, but this bill would really help the Commonwealth. It would help us not only restore some of the business that we lost, not do it our own. Look, I'll take full responsibility for not doing my job. However, a lot of these small businesses that went out of business were women-owned, small business-owned, and they're gone. And I think this bill would help not only motivate us to get back on track, but it also try to get people back in the fitness club to let them know it was safe. And I want to give my colleagues a shout out, because a lot of us, we stuck together and we worked together to stay open. We had all these restrictions with separating people, and you're really dividing people up, and they really haven't come back. So this would be a really good way to get people back. And again, I would ask you to visit your local gyms in the area and see the impact that this bill would do. Thank you for your time, and God bless you all.
Thank you, Mr. Kearney. And there's, do you still ask, would you still like Steve Lemieux, Rick Langella, and Kim Trapello to speak?
Actually, they asked me to talk today. Again, we're all small businesses, so for them to take the time out today would be.
I'm going to give you just a little bit of advice and give you, maybe if you want to add a minute. I think I know what the bill does. I think it's important when you're talking to the committee, and this is for anyone who's here to testify in the bill, state explicitly what this bill will actually do, so that members who are listening know why you're making such an impassioned testimony.
Oh, thank you. I appreciate that. Well, like I said, it would save lives, save time, and save money. We talk about today about our impact on hospitals and Lyme disease and all these other diseases that need our attention. Our hospitals are covered with preventable diseases all the time. 30%. This will not only save time, it'll save money. I do want to share that it will reduce the major illness such as coronary heart disease, stroke, type 2 diabetes, and cancers, and lower your risk of early death by 30%. So this is a huge impact on folks. And I really think if we could get some kind of, this bill also, it gets the messaging out there for us, because
yeah. So I think what you're trying to share with us is this bill is asking for a commission, and it's asking for the Department of Public Health to actually study the impact of gyms on our well-being, along with promoting educational materials, as well as looking at the barriers of cost for people around the Commonwealth to joining a gym, so that everything you're talking about can be shared by those who would benefit.
I wish you were speaking for me. Thank you. I
Well, you
appreciate
did a
it.
good job too. You made people understand the passion behind it and why the impacts are there. Thank you for your time.
Thank you. Thank you. Have a great day.
Yeah, you too. Okay, at this time, I'm going to call, let's see, we have, I don't see Senator Montigny, who's an act improving hepatitis C screening is before us, and I don't see anyone signed up for that. So I'm going to go to the next Senator Montigny bill, which is Senate 1422, an act to improve infection control with long-term care. And I have Leah Lakshmi, and I believe, I don't know if these are, there's no commas here, so I don't know if it's one person or two people. Peepzina Samarishna, and I apologize if I'm not getting that correct. Leah, are you on? Okay. We also have before us Senate 1410, Senator Mark, resolving increasing diagnostic testing preparedness. I don't see anyone signed up right now for that. And so I'm going to give you a heads up. We're going to be calling House 2127, Senate 1409, an act relative to HLTV 111 test. After that, I will call up, if you are here, for House 2177, Senate 1349, an act relative to healthcare worker and first responder safety. So at this time, I would welcome Paul Jakes and Craig Hardy from the Professional Firefighters of Massachusetts. Okay, are you here, Paul or Craig?
Yes, yes, we're here, Representative.
Hi there, welcome.
Hello, how you doing? Thank you for your time. Yes, my name is Craig Hardy, legislative agent with the Professional Firefighters of Massachusetts, and I'm joined with my partner, Paul Jakes, who is also a legislative agent. We represent over 12,000 union firefighters across the state, and we're here to speak on House Bill 2127, an act relative to HLTV 111 test. And we're just here to state that's filed by Bruce Ayers, and also the similar bill in the Senate 1409 filed by Senator Paul Marks. We're here to speak in favor of that. And we're also here to speak in favor of a bill that was spoken up earlier, which is Senate Bill 1349, which was filed by Senator John Cronin, and he was on a committee earlier, a panel, with a couple of doctors. And also in the House, it was filed by Representative Denise Garlick, which is House Bill 2177, which is an act relative to healthcare worker and first responder safety. And we're here in support of that. We also will submit written testimony. But I would just also like to say that just to comment on a few remarks that were made earlier. I mean, this is a common sense bill. And I believe Chair Sear stated earlier, back in the day, it was there to protect people's rights. And we definitely don't ever want to offend anyone's rights. We want to protect everyone's privacies. But this is just a common sense bill to protect the us first responders and all healthcare workers that may be, have some bloodborne pathogens or be exposed to these things, that we don't have to risk taking these medicines or medications that we don't have to, and it just protects us. So it's a common sense bill, and that's all I'd like to say on those two bills, and we're in favor, and we will be submitting written testimony also. And I'd like to thank Chair Sear and Chair Decker, yourself, and the whole committee for letting us speak today.
Thank you. Mr. Jakes, did you want to speak?
I know, just echo my partner, Craig Hardy. Thank you for your time.
Okay, thank you. Thank you both.
Thank you. Have a good.
At this time, I welcome Ben Klein from the GLBTQ Legal Advocates and Defenders, also known as GLAAD. Welcome.
I'm testifying in opposition to the 3 or 4 bills before you that would provide for involuntary non-consensual HIV testing in the instances of occupational exposure. We oppose these bills, and I would also note that Fenway Health has submitted written testimony opposing these bills. We recognize they're well-intentioned, and I think we all deeply appreciate the incredible work and service of healthcare workers, firefighters, first responders. But these bills would undermine important public health objectives in fighting the HIV epidemic And they're also not warranted in light of the science of HIV transmission and the protocols when there is an exposure. So one of the things that's just we can be incredibly grateful for is HIV is a very difficult virus to transmit. It's what doctors call a virus of low infectivity. In other words, in a bloodborne situation, it takes a lot of blood. And those are not the kinds of exposures that happen in occupational contexts. So if we look at since the beginning of the epidemic in about 1981, there were only 58 cases of occupational transmission of HIV. Those were almost entirely before we had the safety protocols that are in effect for decades now. There hasn't been a case of occupational transmission in only one in the last 20 years, and that was a case of a lab worker working with a highly infectious strain of HIV, not the kind of situation we're talking about here. There's never been a case of occupational exposure to a dentist, documented case. Second of all, we do have treatment protocols the CDC and OSHA have established for occupational exposures. And the focus there is on the nature of the exposure, not the HIV status of the source, but what would be called the source patient. In other words, somebody tests negative, they could be in the window period. Okay? They might not be HIV negative. That can give a false sense of security to the person who might not undergo the post-exposure prophylaxis medications. So the status of the source patients is not the key piece of information. The third piece I would just bring forward for your consideration is that there is medication to be taken after an exposure that warrants medication. Not all exposures do. And those medications have been vastly improved, in recent years. They really are safe and well tolerated. It's often one pill a day. It's not the old medication. So for these reasons, we oppose these bills. And I think that if we look at our HIV, the sort of public health imperative to end the epidemic, we need to get people to come forward for testing. And one of the key ways we've been able to do that is to be able to put the word out there that people who are afraid of being tested, that you can't get tested without your consent. That's a simple public health message. So thank you for your time.
Sure. Can we talk a little bit about prophylaxis? These are medications that, frankly, most everyone I know who's a queer person, who's a man who has sex with men, takes. I routinely take PrEP, pre-exposure prophylaxis. I have taken PrEP as well. Can you just talk a little bit about the dynamics of that? Because I think it's important to understand these are medications that are used by thousands of people in the Commonwealth. We actually want these medications to be used more broadly, right, as part of our strategy around how we end the HIV epidemic. And I also think the point you make about the window period is really key. As someone who was an HIV test counselor, both here in Massachusetts and also in New York State, this window period is legitimate, and I do worry about a sense of false security that a first responder or a healthcare worker who does have an occupational exposure could have. And I believe the protocols actually speak to that window period. But can you talk a little bit more about sort of PrEP and PrEP here? Because I think for the uninitiated,
Sure, certainly.
that would be helpful.
Certainly. We have something called HIV pre-exposure prophylaxis, which is taken not in occupational settings, but for people who have more of an ongoing risk of HIV infection. Those medications, there's oral medication, they're now long-acting injectables for pre-exposure prophylaxis. Those medications are close to 100% effective at preventing HIV transmission. They're taken by a lot of people. We obviously need to get more people on PrEP, but they are now being well tested, used in this country, and they're very well tolerated with very few side effects. People take them on a daily basis. For PEP, post-exposure prophylaxis, which will happen if somebody had an occupational exposure that warranted medication. I think part of what we heard earlier was, 20 years ago, when the medications, we would take 3 pills a day, and they were safe, but they did cause more side effects, in the early 2000s. We've had tremendous advances in antiviral medication for HIV. And it's now really, if you're on post-exposure prophylaxis, which is not just given occupationally, but if somebody's had an exposure in a sexual encounter, they take PEP. It's 1 pill a day. It's well tolerated. There are a few side effects, and for PEP, it's for a month. So the medications have really improved and really transformed care in recent years. Thank you.
Thank you. Any other questions? No. Thank you for your time. At this time, I would welcome Tanya Neslison from Mass Equality on House 2177 and Senate 1349. We can't hear you.
Thank you very much. As an organization dedicated to LGBTQ equality, Mass Equality is here in opposition today to an act relative to healthcare worker and first responders safety, as well as an act, the two bills S1409 and H2127, an act relative to HTLV 111 tests. Drawing a blood sample is search and seizure for constitutional purposes because individuals have an expectation of privacy in their blood. And Commonwealth v. Bohegan 486 Mass 209 decided in 2020, the Supreme Judicial Court of Massachusetts concluded that implied consent flatly and unambiguously prohibits blood draws without consent. These bills are discriminatory on their face by singling out HIV as the only bloodborne pathogen identified. As an advocate for the LGBTQ community, I have grave concerns about the language because of singling out HIV over other bloodborne pathogens, contributing to additional stigma against the LGBTQ community. Beyond that, HIV, as we've already discussed, is a virus for which we have prophylactic treatments, including PrEP for pre-exposure and PEP for post-exposure. Anyone who is particularly concerned about their potential risk for exposure can go on PrEP as a long-term treatment protocol to prevent, to decrease their risk. Beyond that, occupational HIV transmission is very rare. There is a less than 1% chance of contracting HIV from a needle stick. Only 58, according to the CDC, only 58 cases of confirmed occupational HIV transmission to healthcare personnel have been reported in the United States, and only one since 1999. There's absolutely no reason for anyone to violate someone's constitutional right to medical privacy to increase stigma, which would actually have no verifiable result. Thank you very much for your time.
Thank you for your testimony. Okay. At this time, I have a panel on the same bill. Dr. Linz Franco and Dr. Elizabeth Connor. Are you with us in person? I have you. Oh, okay. All right. So thank you. We're going to move on to, hold on one second. On to House 2158. And again, we have up to 30 minutes for this. After 30 minutes on this particular bill, we will put a pause on it and come back at the end of the hearing to take as many people as we can. So I am, where is here? Okay. This is an act recognizing EMS as a disease dangerous to the public health, requiring inclusion in MAVEN, establishing the Massachusetts EMS Registry, and requiring biennial reporting as part of the population health trends. At this time, I would welcome Patricia Burke.
Electromagnetic fields. I've moved 22 times in the last decade, including homelessness because my symptoms subside when I'm able to access a low EMF environment. I am being driven from my home again now due to increasing exposures with no apparent options. I'm woken abruptly several times per night with an altered heart rate, headaches, leg cramps, urgent thirst, and microwave hearing. Microwave hearing was recognized by the US military in the 1960s when it was determined that radar operators could hear microwaves outside the normal hearing range. Studies show absorption of microwave pulses by soft tissue in the head that launches a thermoelastic pressure wave that travels along the bones to the inner ear. Alan Frey's research proved definitively that deaf individuals and animals can hear microwaves through this mechanism. Microwave hearing is widely accepted in the medical literature, but the military was testing adult male radar operators working during the day and not families attempting to live, sleep, and heal in their own homes at night. I have yet to work with a mainstream medical practitioner knowledgeable about microwave hearing, which is not tinnitus from an unknown source, or a practitioner trained in microwave illness. There is a lack of practitioners trained in this area. The health risks of poor sleep are well documented, including endangering others through drowsy driving. In January 2023, I contacted the local health boards about increasing exposures and symptoms. These reports are dropped calls because no one is quantifying them. EMS is a distinct set of recognizable symptoms reflecting oxidative injury, cellular stress, and membrane alterations, as noted in Dr. Cindy Russell's testimony. For research to access data integrity, it has to be compiled. Massachusetts can collect actionable, accurate data. Please establish the registry. Thank you.
Thank you. At this time, I would welcome Cece Doucette.
Good morning and thank you. I'm Cece Doucette, Director of Massachusetts for Safe Technology, and I am contacted daily by citizens whose towns and health authorities have no way to help them with electromagnetic illness. The Department of Elementary and Secondary Education has told me we are waiting for higher authorities to tell us what to do. We need your leadership and this law. The Earth pulses healthy electromagnetic energy at 7.83 times per second. Wireless technology pulses man-made radio frequency microwaves in the megahertz and the gigahertz range. That's 1,000,000 and 1,000,000,000 times per second. We are getting bombarded with microwaves from wireless tech. Quite simply, wireless radiation overpowers our own biological cells. Science indicates that we should be at 10 microwatts per square meter of radio frequency energy. And here in this room with everybody's devices and the wireless infrastructure, we are at 13,700 and we should be at 10. While others will provide facts on why we need to include electromagnetic sensitivity in MAVEN, I'm excited to share with you resources to address the second part of the bill, which is the education of citizens and healthcare practitioners. We have already drafted a public health fact sheet on EMFs with Dr. Robert Knorr and Glennon Barrison at the DPH. House 2158 would allow this to be released to the public and medical teams. The Massachusetts Breast Cancer Coalition has already developed K-12 curriculum for our schools. With Finland's Dr. Mikko Ahonen, I have built a schools and families course. We can train the public in about a half an hour online. For healthcare practitioners, the EMF, for Electromagnetic Fields Medical Conference, now offers 24.5 continuing medical education credits to recognize, diagnose, treat, and prevent electromagnetic illness. The presenters are among those authored in this bill with the materials recommended. Firefighters require continuing education too, They appreciate that this conference can be completed online, and they have been harmed gravely by cell towers. Please see Susan Foster's testimony. We now have the first medical school textbook, just came out this year, Electromagnetic Fields of Wireless Communication, Biological and Health Effects. And Dr. Cindy Russell, who has also submitted testimony to you, has Physicians for Safe Technology. So we've got it covered. Thank you.
Very much. You're welcome to submit additional
Any
testimony.
questions I might help with?
I'll ask the panelists if they have any. No? Okay, thanks for your time. I'm going to go to our virtual folks and call on, it'll be Deb Chandler, Hank Allen, and then Kenneth Gardner. Deborah? Deborah, we can't hear you.
Can you hear me now?
We can. Welcome.
Okay, thank you very much. Dear esteemed legislators, my name is Deborah Chandler, and I currently live in South Hadley. I'm here on video today so that I can avoid being exposed to the very EMFs that have caused my chronic condition. A few years ago, when I testified at the State House, the EMS caused my nervous system to go into overload and I could barely finish my testimony. I've been a graphic designer since 1980s. My bachelor's degree is from Mass College of Art. The tools of my trade have evolved tremendously over the decades. I went from T-squares to computer screens, hardwired to all things wireless, connecting to a global village at the snap of a finger. For a while, it all seemed so fantastic. Then I slowly started getting chronic symptoms of trembling, heart arrhythmia, migraines, flu-like symptoms, dry cough, heartburn, GI upset, eye pain, and muscle pain. Then the anxiety, the brain fog, and inability to organize my thoughts. I started to stutter, lose fine motor skills, have dizziness and vertigo. It took years before I realized this is EMS. And when I stay away from the sources of exposure, the symptoms subside. The walls of that wireless global village have closed in on me. I can no longer earn a living doing my beloved graphic design. I can only be on the laptop for a short time. I must be very brief at the bank, the grocery store. I'm very sound sensitive and light sensitive. I wear shields, earplugs, glasses. I carry my EMF meter everywhere I go. I must say no to most invitations. My friends and family and business colleagues just don't understand. They've never heard of this crazy making EMS. And I cannot find affordable EMF safe housing, so I've come up with an ambitious plan. I will build a tiny house village far away from EMF sources. I have a list of at least 50 people, EMF refugees, showing avid interest. But we need to figure out our own funding as our needs do not fit with existing government programs. Isn't it a shame that we have to figure out how to build our own little secluded village? We are here today to ask that you recognize EMS as a disease dangerous to the public health and to get it included in the MAVEN database. It needs to be tracked and diagnosed by the mainstream medical establishment, and insurance needs to cover our health care, and we need accommodation. There are a growing number of people with EMS who have reached a point of hopelessness. They don't know how to access or express or manage their pain. Many have tragically ended their lives. Please, let's put an end to this. Let's get EMS on the list of recognized diseases. Let's stop the silence and the gaslighting, stop the deadly downward spiral of our mental health, and start giving EMS the validity it deserves. Let's take this invisible illness and make it really visible. Thank you for listening and playing your important legislative role.
Thank you for your time. At this time, I'm going to welcome Hank Allen and then Kenneth Gardner.
Excuse me, I signed up to speak with this bill and I have not been named.
So we've just started the testimony for this bill, and we're taking up to 30 minutes of testimony as I had shared earlier. And at the end, if you haven't heard your name, we will come back. But at this time, I'm going to welcome Hank Allen and ask everyone else to please mute. Hank, are you with us? Okay. Kenneth Gardner.
Yes, thank you. All right, my name is Ken Gardner. I'm resident of Warren, Massachusetts. Today, I'm speaking in support of H 2158 to add electromagnetic sensitivity to the list of tracked health conditions in the state's MAVEN database. The steady rise of new EMS cases across the U.S. suggests a public health situation that is in desperate need of the quantitative analytics and case management strengths offered by MAVEN. The condition of electromagnetic sensitivity has long existed, initially as neurasthenia in the late 1800s, as radar man's illness in the mid-1900s, and more recently as microwave illness or electro-hypersensitivity. This condition can arise suddenly and persist for years if not addressed promptly. Based on a comprehensive EMS population analysis in Sweden, 3% also seems a reasonable EMS population estimate here in Massachusetts. Integration into MAVEN will refine such estimates using real case data. Electromagnetic sensitivity is a condition which has a mild form that, when left unaddressed, often progresses to the debilitating form which is both stultifying and difficult to cure. Individuals who progress to such advanced EMS cannot easily participate in society, hold steady employment, and sometimes can no longer tolerate living in their own homes. EMS is primarily a condition that is tied to environmental exposure, often beyond the control of the afflicted individual. Over time, the case reporting and management aspects of MAVEN will allow engagement with the broader public health infrastructure so as to catch burgeoning EMS cases, to integrate into behavioral risk factor surveys, to tap into the school nurse surveillance program, to quantify the true costs to society, to identify preventive measures, to encourage physicians to look for the signs, to promote development of effective diagnostic tests, to identify clusters of EMS tied to a single environmental hazard, and to craft public awareness campaign messages that encourage healthy habits with respect to electromagnetic exposure. As a practicing building biologist here in the Commonwealth, I personally know dozens of households who have at least one member with EMS. In my own household, my partner suddenly contracted EMS in 2019 and remains effectively housebound within her unelectrified sanctuary. Traveling outside the home offers too much physical insult to be borne. In hindsight, this health situation could have been prevented if the early warning signs were generally known and if her medical team had been educated about this novel condition. Let us hope that integration into MAVEN prevents this unpleasant outcome for others. Thank you.
Thank you. At this time, I'm going to welcome a panel up, and there's two of you who've signed up, Courtney Gilardi and Amelia. And just so that you know, Representative Farley Bouvier, who has filed this bill, actually has not able to be here today, but has called me to talk extensively about the bill. Welcome, Courtney and Amelia.
Thank you. Yep. Esteemed legislators, my name is Amelia and I have electromagnetic sensitivity. I was diagnosed after an exposure to high levels of electromagnetic fields. I want to thank State Representatives Farley Bouvier, Howard, and Keefe for sponsoring this recognition and registry bill to document people like myself and my sister who suffer from this condition. It is vital the EMS is included in a public health reporting system. Over 17 people in my neighborhood experienced symptoms while being sick. We were also calling, advocating, and asking everyone in our city for help. No one was documenting us. No one knew what to do. We learned after the fact that when other people became ill from EMF exposure elsewhere in Pittsfield and around the state, that they too had called for help, and no one documented their symptoms or provided resources. This condition is life-altering, and victims of harm deserve care. They should not have to self-advocate all this time when they are suffering and sleeping in their own cars. After 7 months of being sick in my own home due to this exposure, I was forced to leave and simply sleep elsewhere so I wouldn't vomit in my own bed or wake up feeling so dizzy that I would walk into a wall. On the worst days, I couldn't even concentrate on my schoolwork, and sometimes I couldn't even attend school. My little sister's EMS symptoms were worse. She would get rashes, she would get nauseous, she lost her appetite. When she was in her bedroom, which was closest to the source of the emissions, she would feel like her skin was crawling. Our state representative, Tricia Farley Bouvier, and Pittsfield city councilors have known we have had to go to the doctor, sometimes every 2 weeks. After 7 months on their advice, we started sleeping elsewhere. This was on mattresses on the floor at a 100-year-old rodent-infested cottage with no shower or hot water. And for the first time in 7 months, we actually started sleeping and found some relief. We didn't have to take children's Tylenol for headaches or Pepto for nausea or Benadryl for skin rashes. We didn't have to sleep with a vomiting bucket beside our head. Kids get sick from exposure as we absorb more wireless radiation. We are more prone to EMS as our skulls are thinner, our frames are tinier, and our bodies are still developing. Documenting how many of us there are with EMS is an important step. To this end, I ask for your vote. I ask each of you to please pass this vital health and safety legislation. The toxin causing our illness may be invisible, but we are not. So thank you for your support.
Thank you. Thank you both.
My name is Courtney Gilardi.
Courtney, you have, did we do separate 3 minutes? Okay, go ahead.
Thank you, esteemed legislators, in advance for your support on House Bill 2158. I will send you my personal comments and experience with EHS, but today I woke up to a picture of a young girl in our local newspaper, and she was holding a sign that said, "Being believed shouldn't be a battle." It reminded me of powerful comments that my then 14-year-old daughter Amelia shared with her city council and board of health a year ago this month on recognizing EHS, and I want to share with you her words. On May 12th, the National Council on Disabilities discussed our illness, EHS, and the lack of understanding, empathy, access to healthcare, and safe housing that is associated with it. Council members and doctors discussed proposed solutions that may take years or even decades to implement. And people have been fighting for recognition for over 20 years, where you have the power to help those suffering right now. Thank you for believing me when I tell you, when my doctors tell you, when the subject matter experts tell you that I have been injured by wireless radiation. Thank you for letting the doctors and experts make the determination of harm instead of the news or the media telling you. They don't know us. They have never spoken to us or our doctors, and they have no right to judge or to make statements about us. The Berkshire Eagle had an article over the weekend about survivors of sexual assault, and it referenced an international campaign called Start by Believing. You can pledge that when someone tells you what happened, that you not only believe them, but you support them by taking action, by being an upstander, not a bystander. And this is what each of you are doing with electromagnetic sensitivity. You are listening to us today. By taking this action, you support us on the road to healing and justice. By taking a stand for public health and safety, by documenting and recognizing us, you are helping to end the stigma and silence of this disease. We know that speaking up and taking action comes with a cost. It can take a toll on your mental health. People no longer speak up because they have been broken by the derogatory comments and the judgments. And as a kid, it is hard to be a victim of this shaming. As a leader, I am looking to you for solidarity and protection. What makes this easier is to know that after this 1,000-day fight, I am not alone. The good people like you are listening and taking action. To us and to the 150 plus safe technology groups comprised of people who are injured by wireless across our nation, advocating for care, education, and recognition, you are our heroes and leaders. Sorry, that was my timer. The work begins with children like my daughter Amelia, my neighbors, myself, and the good people here today testifying on EHS being counted. Thank you for your vote of support for H2158 today.
Thank you both. At this time, I would welcome up Paul Harding. Okay, Paul, are you there? We're going to move on to Michael Muadin.
Thank you, Chair.
Michael, are you there?
My name is Michael Muadin. As
Welcome.
president of the, can you hear me?
Yes, we can hear you.
Okay. As president of the Alliance for Microwave Radiation Accountability, I've encountered many of the millions of people across the United States who've been disabled by severe chronic electromagnetic sensitivity, a sickness studied and documented for 70 years as classic microwave radiation syndrome. In the beginning, the body heals more easily, but as the illness worsens, it loses the ability to recover. Sensitivity increases, and symptoms are triggered by lower doses of radiation and briefer periods of exposure. Effects continue to compound until the full onset of the illness long known as microwave radiation syndrome. When their condition is so bad they no longer recover, the victims are forced to withdraw from society, becoming refugees, no longer able to tolerate additional exposure to radiation from any source. The injured lose their civil rights and access to medical care, the legal system, and government. They can't walk into City Hall, a courthouse, a library, a bank, or a hospital. They're no longer able to go shopping for food or clothing. Every store is off limits due to the radiation from Wi-Fi and cell phones. Any further exposure robs the victims of the rest of their ability to use any electricity or electrical devices. It crashes their immune system, devastates their mental health, destroys the rest of their physical health, and finally ends their lives. The victims grow old, fast, and die. That's why the military called microwave radiation sickness rapid aging syndrome when it was first detected in radar operators decades ago. Honorable legislators, you have a major public health crisis on your hands, and you need to begin tracking the tragedy unfolding all around you, laying waste to the health, safety, and welfare of your communities. It is a necessary first step toward granting the victims formal recognition of our illness and disability, equal access to public spaces, and justice for our suffering. It takes a certain fearlessness to turn the tide of events and shape the course of human history. We urge you to have the courage to pass Massachusetts House Bill 2158 and establish a registry for those who suffer from electromagnetic sensitivity, the victims of microwave radiation syndrome.
Thank you.
for your
Thank you
time
very
and kindness.
much. At this time, I'm going to call Eva and then Shelley Wright. Eva? Or Ava? Okay, I'm going to move on to Shelley Wright.
Hello.
Welcome.
Thank you for this opportunity, esteemed legislators. I'm the director of a national nonprofit organization called Canadian Educators for Safe Technology. We support a growing number of students and teachers who are now injured by Wi-Fi microwave frequency radiation. I have a physician diagnosis called electromagnetic hypersensitivity, EHS. I was diagnosed by the director of the environmental clinic at Women's College Hospital in Toronto. EHS or EMS is an environmentally induced intolerance to microwave frequency emissions. Since I have become crippled by the pervasive use of wireless devices, I've become a strong advocate for accessibility in educational and health medical facilities. Physician-diagnosed EMS patients experience common microwave frequency-induced microwave sickness symptoms. Cardiac and neurological symptoms appear to be the most serious. Symptoms include debilitating migraines, loss of executive functioning, life-threatening vertigo or disorientation, and cardiac symptoms including pressure in the chest and irregular heartbeat. Many of these symptoms are linked to strokes and brain tumors. Those who are severely impacted may not recover for days or weeks. For some electrosensitive people, the impact of wireless RF exposures can trigger severe and permanent injury. According to integrative cardiologist Stephen Sinatra, people experiencing tachycardia around modulated microwave frequency emissions can also experience increased risk of stroke or heart failure. A child from Simcoe was 6 weeks from heart surgery when her heart monitor showed symptoms only at school. Her cardiologist canceled her surgery. Although accommodations at school are possible, she is now homeschooled and okay. Vulnerable people, including children who are physician diagnosed with EMS, may not be able to walk down their street or access essential services, including shelter, without becoming severely injured by wireless microwave frequency emissions, which can impact the public right-of-way. EMS people have no choice but to limit their participation in society to prevent serious or fatal injury. They can no longer access hospitals, medical clinics, public transportation, and other essential services which were once wired but now forcefully emit industrial strength density of RF emissions, even if no one is actively using those signals. EMFs are also known as a causal cofactor for serious autoimmune diseases like ALS, multiple sclerosis, and Parkinson's. According to cancer epidemiologist Dr. Anthony Miller, Professor Emeritus of Dalai Lama School of Health and Senior Scientist for the International Agency for Research on Cancer, IARC, additional RF exposures can increase the risk for brain cancer, especially among people with medical susceptibilities. An EMS disease registry, advisory committee, data collection, and distribution of educational materials in medical clinics and hospitals are urgently needed. EMS requires inclusion
Shelley,
and
thank
Maven.
you.
Thank you.
Thank you. Please do feel free to submit your written testimony. At this time, I see that Eva actually is here.
Yes, thank you.
Welcome.
Hello, my name is Eva Portnick, and I live in Oregon. I am an electro refugee, one of the many untold thousands of suffering and internally displaced disabled people within our country whose lives have been destroyed and who have no place to be because of the digital wireless proliferation, which has occurred over the past 25 years. We have lost our families, friends, ability to work in our homes. We face enormous discrimination due to the invisibility of the substance that assaults us and the injuries which are internal, as well as because of actions and negligence by federal agencies that are supposed to be assisting and protecting us. The Defense Intelligence Agency admonished in 1977 that if the more advanced nations of the West are strict in the enforcement of stringent exposure standards, there could be unfavorable effects on industrial output and military function. Further, they said recognition of the 0.01 milliwatts per centimeter square standard could also limit the application of new technology by making commercial exploitation of some products unattractive because of the increased costs imposed by the need for additional safeguards. In 1968, however, Congress passed the Radiation Control for Health and Safety Act, which was supposed to be implemented by the Department of Health and Human Services, which included a mandate to stay on top of the science and biological harm from radiation, to form a committee which includes members of the public and workers in order to make sure that safety was being addressed, and to submit periodic reports on the current science related to safety for Congress. None of this has been done for decades. Subsequently, the radiation regulatory responsibility has fallen on those injured and other concerned citizens. I appeal to you today to save the lives, health, and families of children and to protect the vulnerable from the giant radiation regulatory gap. Society must stop saying that because radiation is invisible, it is free, and we can keep putting unlimited amounts into the atmosphere. I'm submitting documents that support my comments and the passage of this bill, which I hope will also encourage you to take further steps to stem the harm from continuing proliferation of transmitters on and inside everything. Thank you for your time.
Thank you for your time.
Chair Duncan?
Yeah, Senator
Yeah, I mean,
Spear.
just, I'm mindful, right, we've allocated about like a half hour for this testimony. We're coming to the end of it. I'm a little disappointed that we have so many, I just want to tell the advocates who are on there, right, that all this airtime we're getting from people who do not live in Massachusetts, who are not Massachusetts residents, means that Massachusetts residents are not testifying to this committee. And while I respect whatever's happening in Oregon and Idaho and God knows where else, I care about the perspective of our residents and constituents here in Massachusetts. So just a reminder to advocates that the more out-of-state people you get testifying here, means that we're not going to hear from people in Massachusetts. I think that's a real disservice. My job, our job at this committee is to hear from the people of Massachusetts, and with all due respect for folks who are weighing in, if you're weighing in from corners outside of the Commonwealth, maybe it's best if you do that testimony by written testimony, because I think we're not going to hear from a lot of Massachusetts residents who have concerns on legislation because of the out-of-state focus. So this was just my comments I wanted to share.
Thank you, Senator. At this time, we have given 30 minutes to this testimony. If we have time at the end of the hearing, we will come back and pick up the rest of those who haven't been able to testify. If you have written testimony, please feel free to send that to our staff. If it is difficult for you to write or email, we will set aside a few minutes of time for you to have a conversation with the staff person and prioritize the best we can to ensure that all Massachusetts residents can also communicate with us. At this time, I want to welcome Representative Mindy Domb, who has joined us in person. And you can remind us of which bill you're earlier. Welcome.
So much, and I so appreciate those comments, Chairman Sear, and the dedication of this committee to making sure that Massachusetts residents have an opportunity to speak on issues of concern to them. I'm Mindy Domb, and I'm the state representative for the 3rd Hampshire District, which includes the towns of Amherst and Hartford Granby. Thank you so much, Madam Chair, and Chair Sear and members of this committee. I'm honored to be before you to speak about some bills today. I'll really be limiting my talk to speaking in support of the bill that sets up a commission to look at long COVID, but I'll be submitting testimony in writing on some other bills that are before you today. And I really do appreciate this opportunity. Part, I think, of what is vexing about long COVID is that it sometimes is unseen or unrecognized. And so being able to speak on it, and it's also, I hope, meeting some of that need from folks. Today I sit before you unmasked, fully vaccinated against COVID-19, and a day after taking a stroll with my town's downtown economic director to learn about our community's comeback after 2022. We clearly all want to move on from the early days of the pandemic, the screaming sirens on streets in our cities, the banging of pots and pans in honor and gratitude to first responders and medical providers. We want to move on. In the legislature, we've taken lessons learned from the pandemic and we've put them into statute. We took telehealth, vote by mail, virtual hearings, and more. And we've advanced them as a lesson learned from this period of time. We've recognized that these were practical and important policy improvements that surpassed the initial pandemic's impact. The public health emergency expires next week. We talk about the before times. We want to move on, but we can't completely. Notwithstanding the people who are currently getting infected and sick from COVID-19 and continue to die from it, many more people in our Commonwealth and our country and the world are struggling with persistent symptoms known as long COVID. Their experience and their struggle warrant our recognition, our attention, and our action. To do so will benefit them and their families, but it will also benefit all of us. Not just because it feels good to take care of other people. It will benefit us by helping us in specific ways, including it will expand our knowledge in ways we cannot yet grasp, resulting in scientific and social breakthroughs for people experiencing other illnesses. It will identify gaps and remedies for those services for people who are experiencing illness and disability. And it will increase our understanding of caring for people with chronic illness. In thinking about long COVID and what we can do, I was overwhelmed, and I think it can be overwhelming. The areas that require our attention and where our residents are feeling the struggle include medical and medical education, research and understanding, public information, treatment, social services and support, financial and insurance issues, employment accommodations, workforce challenges, and for my end of it, especially surveillance, data collection, and reporting. And I just wanted to take a moment to say, we might think surveillance and data collection, I know this committee doesn't because you're public health and you're right on this. Many people think surveillance and data collection are not that important. But if the tree falls in the forest, and the forest is our Commonwealth, and the tree are our people, the only way we hear about it The way that sound gets amplified is through surveillance, data collection, and reporting. And if we don't hear it, we don't see it. So we need to start grappling with that. Many of us remember in the early days of the HIV epidemic, fighting for these very same efforts. What comes next in the COVID-19 story is a chapter that can feel very familiar. This is the reason for this bill. And this is why I'm here to urge favorable action and gratitude for the timing of this hearing. For Resolve H2147 to create a special commission to identify the needs of long COVID and prioritize them for government action. We need a punch list and a roadmap. My hope is this commission will help us focus on this continuing issue in meaningful ways. You'll hear today, and you might have already heard, and you'll receive testimony, that we are just beginning to understand diagnosis, treatment, and care issues involved with long COVID. The symptoms vary on a case-by-case basis, which makes it difficult to identify, track, and address. The term long COVID was first used by patients to describe their ongoing symptoms following a diagnosis of COVID-19. There have been continuous efforts by the community of patients and the medical community to recognize the impact of long COVID and to address its prevalence, risk factors, and treatment options. According to the CDC, 1 in 13 adults in the United States have symptoms of long COVID. I want to acknowledge the important and good work of many people, many of whom are in the Boston area, researching and understanding the impact of long COVID. You'll hear from some of them today, especially those from the COVID Recovery Center and other professional working groups. Currently, the National Academy of Science is soliciting the public's comments on what should be included in the surveillance definition for long COVID. I find it incredibly interesting that they're soliciting from the public to recognize the expertise that patients have and should have in crafting this definition. But I think it also makes this commission more urgent so that we can be readily formed when the surveillance definition is set, and we can go about implementing it in a meaningful way for our Commonwealth. Today, you'll hear from researchers, patients, advocates, medical providers. You'll learn about the racial disparities and the regional inequities in people's experiences with long COVID and their ability to access and deliver services. You'll hear about people suffering with persistent symptoms and a medical community that is ill-equipped in a consistent way to address and respond to it. According to the World Health Organization, another staggering statistic, an estimated 1 in 10 COVID-19 cases, not individuals. So some people get repeated infections. So it's 1 in 10 COVID-19 cases result in a need for long-term care. The need for information about long COVID continues to grow urgent for all stakeholders, individuals and their families and neighborhoods, medical providers, physicians, the mental health community, human services. I'm almost done, Madam Chair. One more. Every day, more and more residents in the Commonwealth, their families, and their providers struggle with living with long COVID. Some are disbelieved, some are ignored. Many are missing hours of work and wages. Families and relationships are strained. Many remained concerned about reinfection, some facing financial stress because of their missed work. Medical providers are literally scratching their heads because they don't have the adequate information to be able to treat their patients. Isolation is an ongoing and intensifying experience. The commission that this bill would create is designed to support us as a legislature and our Commonwealth to prioritize our actions with regard to long COVID and its extended reach into our communities. It's another lesson we can learn and can implement from the pandemic, acknowledging the existence and complexity of long COVID, finding our lane, and addressing the services we need to support and address our constituents' suffering. In doing so, we take the next step to write the next chapter. Thank you so much, and I welcome your questions.
Thank you, Representative. That cough was genuine. You know, I'm not that subtle. I truly appreciate you've been an incredible public health voice for the last 3 years and appreciate your testimony and your work.
Thank you so much, Manager.
Thank you.
Thank you.
Thank you.
Okay. At this time, I'm going to recognize the Honorable Mike Festa, Director of the AARP. I should get it right. I'm now like an eligible member. House, you will be too someday. House 2178, Senate 1380. Honorable Festa, are you here with us? Okay. Once a colleague, always a colleague.
Madam Chair, I believe it's only because the criteria for joining the AARP is so low. I think it's at like 45 or 50, right?
No, I own it. I'm 50. I'm proud of it. This is what 50 looks like. Is he coming on? Oh, here he is. Okay. Welcome, Mike. We need you to unmute if you're there. Okay, you might be there, but not be there. We will come back to you. At this time, I'm going to welcome, same bill, Jim Wessler, the CEO of the Alzheimer's Association, Judy Johansson and Catherine O'Malley. I see that there's 3 of you on a panel. Just please note that you have 6 minutes, so be mindful of each other's time. Okay, welcome.
Watertown, and Alzheimer's has made me a widow. In 2010, my handsome 57-year-old husband was in the prime of his life. He was a construction project manager at Northeastern University. We had 1 child married, grandchildren on the way, another child getting married. We had it all. But we were trying to avoid facing the troubling symptoms that were becoming harder to ignore. Forgotten passwords, lost keys, financial missteps, getting lost while driving in familiar places, apathy, and more. Steve was feeling concerned about his memory and his attention span, so he brought it up to his primary care physician and asked him what he thought. The primary care physician responded that Steve was likely tired, and sometimes as couples age, they tune each other out. That was not Steve and I, but and that Steve was too young to be concerned about Alzheimer's. And until work said something, don't worry about it. Well, on May 5th, 2011, Steve received a poor performance review. We had kept our concerns to ourselves and endured these concerns on our own until that poor performance review. At that time, 5 months of testing led us to a diagnosis of younger onset Alzheimer's. We scoured the internet for information and for resources. How could this be? At 58 years old, he could have Alzheimer's. Steve needed to leave his job immediately, and eventually I needed to leave mine to care for him. Alzheimer's is a relentless opponent that affects much more than just memory. Eventually, it let us know that it would not give up and it would take him over completely and take him away from me on April 2nd, 2018. When I think back to those early warning signs, when we didn't know what to do or where to go, I regret that I wasn't better informed and maybe could have spared Steve from some of the sad and isolating moments that he experienced, especially when I think about him at work. I advocate for this bill to promote awareness and access to needed care and services so other families don't go through the isolation that this disease can bring. I also share our story to emphasize that Steve was diagnosed with Alzheimer's in his 50s. This is not an aging issue or something that happens only to seniors. This can happen in the prime of someone's life, as it did to us. This is a growing public health issue that needs to be known about and treated as such by the public and government. On behalf of all the residents in Massachusetts living with or caring for someone with Alzheimer's disease, I respectfully urge you to support this important legislature. Thank you so much.
Thank you, Judy. Chairman Decker, Chairman Sayre, members of the Joint Committee. I don't know if my own state representative Kay Khan is still with us, but greetings. Greetings to her. My name is Jim Wessler. I'm the CEO of the Massachusetts New Hampshire chapter of the Alzheimer's Association. I live in Auburn, Massachusetts. We thank you for the opportunity to testify in support of House Bill 2178 and Senate Bill 1380. In 2018, this legislature passed an omnibus bill entitled An Act Relative to Alzheimer's and Related Dementias in the Commonwealth. A really remarkable bill, probably the most comprehensive in the nation at its time. One of the very successful measures created by this bill was the establishment of a permanent advisory council on Alzheimer's disease to coordinate government efforts and ensure that appropriate resources are maximized and leveraged. I was appointed to serve on that council. The passage of House Bill, this bill before you is the logical next step to make sure that we are addressing the public health crisis of Alzheimer's disease, of which Judy's story is one of 130,000 in the Commonwealth. The bill will raise awareness of Alzheimer's and other dementia through the creation of a public awareness campaign on brain health and resources, which the Department of Public Health would incorporate into its existing relevant public health outreach programs on an ongoing basis. The bill, secondly, ensures the collection of relevant public health data, and we've heard about the importance of data with other bills. Data collection is critical as it will help us understand the impact.
Your third friend needs to speak.
So anyway, this bill enables us to collect important data in several ways. Finally, the bill establishes a position within state government to address Alzheimer's disease and support this coordinated effort. 24 states plus the District of Columbia have a dementia care coordination position. It's time that Massachusetts join that. I'm going to turn it over to Josh.
Thank you. My name is Catherine. I'm here because my brother had Alzheimer's. My mom's mom was in the audience with us. I know we're short on time, but something we just want to highlight for this bill and for Alzheimer's legislation is that Alzheimer's is a public health crisis. So as the population increases and the baby boomers increase, so too does the prevalence of the disease. And that increases costs as well. So Medicaid costs for caring of people in Alzheimer's in Massachusetts in 2020 was $1.75 billion, and that will grow to over $2 billion by 2020. So for us to highlight that as well.
Thank you. Thank you for testifying. And I encourage you to also submit your testimony. Judy, thank you for your generosity of coming here and sharing your story as well.
Thank you.
Thank you very much.
At this time, Mike Festa, are you here? The
I am,
Honorable
Madam
Festa,
Chair.
glad to have you here.
Yeah, it's good to be here. You know, it's Murphy's Law, right? Hi, Kay Khan. I can see you on, and all the members of the committee. No, the Murphy's Law is I've been watching intently for 2 hours, and I got a quick call, and there you go. Anyway, it's an honor to be testifying today with respect to the 2 Alzheimer's bills that are pending. My name is Mike Festa. I am the state director for AARP in Massachusetts. And I just want to say right off the bat, you know, we're going to be submitting full written testimony, so I won't read it and I won't do all, you know, cover everything that we're doing in the, you know, in the written testimony. But I do want to highlight a couple of points. I mean, first and foremost, when I listen to Jim Wessler and the folks at the Alzheimer's, I'm reminded, and I'm sure you are too, that Alzheimer's is a big challenge. It's a big challenge for those who are living with it, the big challenge for the caregivers, and even more of a challenge ultimately to society because of the, you know, frankly, the impacts it has on long-term care and other issues. And so whatever we can do to get our arms around the details and the data and to plan better for addressing issues of dementia, I think that is the best thing. We certainly feel that way at ARP, that policies that focus on that are really important. We know the human and the societal and the financial costs are all very high. They impact healthcare costs. They impact people's lives, as you've heard and know. And the costs are huge to this Commonwealth. Just $9 billion, they say, in additional healthcare costs just due to the emotional toll of caregiving, let alone the impact on the healthcare, long-term healthcare system. So at AARP, you know, we believe it's really important, both federally and state, that there be a focus on ensuring, number one, that there's sufficient funding for long-term public education around this, as well as raising generally public awareness of the challenges of Alzheimer's and supporting people in this regard. And I also want to make note that there's a great dementia-friendly movement that's happening around the Commonwealth, for which AARP Massachusetts has been a strong supporter. What we believe is that both the House Bill 2178 and Senate Bill 1380 really will address appropriately, and I think, frankly, reasonably, our public health infrastructure to examine, what are we doing about Alzheimer's, how are we addressing these concerns, and how we can better organize the effort at the state level. So we think that these bills are absolutely essential and certainly should be favorably reported out of this committee. And I just want to end by thanking each and every one of the committee members for the good work you're doing in trying to address Alzheimer's, not just in this legislation, but in other matters of this nature. And again, a shout out to my dear friend Kay Khan in particular, and others I've served with over in now ancient days, Kay. It's been a while. But anyway, I'm here to answer any questions. And again, we'll submit written testimony as well.
Great. Thank you.
Thank you.
Appreciate your work.
Thank you.
Okay. At this time, with no one else signed up for testimony in that bill, we're going to move on to House 3614, Senate 1344, an act to improve outcomes for individuals with Parkinson's disease. And we have Zachary Hardy from the Michael J. Fox Foundation for Parkinson's Research. Welcome.
Thank you so much, Chair. Good morning, Chairman Sear, Chairwoman Decker, and members of the committee. My name is Zachary Hardy, and I am a State Government Relations Officer for the Michael J. Fox Foundation for Parkinson's Research. Thank you for the opportunity to testify before this committee on H3614 and S1344, which would establish a Parkinson's disease research registry in Massachusetts. The Michael J. Fox Foundation for Parkinson's Research was founded in 2000 and has been singularly dedicated to finding a cure for Parkinson's disease through an aggressively funded research agenda and to ensuring the development of improved therapies for those living with Parkinson's today. The Fox Foundation believes that establishing statewide research registries is a critical step to understanding Parkinson's. A Massachusetts Parkinson's disease research registry will provide data on the incidence and prevalence of the disease and its various patterns in the state. This registry will provide a real-world view of clinical practice and patient outcomes, while exploring geographic clusters, disparities in treatment for underrepresented communities, and the link between military service and the development of Parkinson's. This data would help identify high-risk groups, support patient contact studies, and serve as a valuable data resource to prevent and optimally manage Parkinson's disease. This legislation builds on the work of an advisory committee that was formed by the Massachusetts Department of Public Health as a part of the FY 2022 budget. The committee, which was comprised of neurologists, Parkinson's disease researchers, and a person living with Parkinson's, discussed the benefits and challenges related to establishing a research registry. Their work concluded with the issuance of a final report in May of 2022. This legislation would reinstate the advisory committee and begin the process of implementing their recommendations on creating the research registry within the Department of Public Health. Massachusetts would be joining California, Nebraska, South Carolina, Utah, Washington, West Virginia, and as of just yesterday, Maryland, in establishing a research registry dedicated to Parkinson's disease. There are estimated to be over 1 million Americans currently living with Parkinson's disease, with about 90,000 more diagnosed each year. The national cost associated with Parkinson's is approximately $52 billion per year, with the cost projected to rise to nearly $80 billion by 2037. According to the Centers for Disease Control and Prevention, Parkinson's disease is the second most common and the fastest growing neurological disease in the world. The direct and indirect costs to care for the over 21,000 people, which we believe to be an undercount, living with Parkinson's in Massachusetts, is $1.1 billion per year. Finding new treatments and ultimately a cure will not only greatly benefit the health and livelihood of the Parkinson's community, but would save hundreds of millions of dollars each year. On behalf of the Fox Foundation and the patients that we support, we urge a favorable report on H3614 and S1344. Thank you so much for your time and happy to answer any questions.
Thank you for your time. At this time, I'm going to welcome a panel of Bill Patchen, Rosemary Owen, and Kathy Thomas. And to remind you, you have 6 minutes. Please try to be mindful of each other of the full 6 minutes.
Good morning, chairs and members of the Legislative Committee. We are here to talk about H2170, an act relative to Parkinson's disease, public awareness and education. And I'll start. My name is Kathy Thomas. I reside in Quincy, Massachusetts, and I'm a nurse. I work directly with individuals with Parkinson's disease and their family members for greater than 40 years. I'm currently the program director of the Parkinson's Disease and Movement Disorder Center at Boston University Medical Campus and participate in both patient care and research. And I have coordinated services with my colleague Rosemary Owen with our on-site APDA Information and Referral Center, which is funded by the American Parkinson's Disease Association. I'll share Parkinson's disease is complex. It's a chronic progressive neurological condition affecting over, as we just heard, at least 21,000 people in our Commonwealth, but as we recently heard, the number is probably much higher. Progress has been made in diagnosing people earlier in the course of their illness, and studies suggest that over the next 2 decades, there will be a significant increase in the number of people diagnosed with Parkinson's. It's well established that Parkinson creates significant strain on not only the person living with this condition, but also their family caregivers. When most people think of Parkinson's, they think of tremor, slow movement, difficulty walking, and an increased risk of falling. But what is often not known is that people have a number of non-motor problems affecting mood and behavior, sleep, speech, and cognition. I fully support this bill presented by Representative Galvin in hopes that it will improve an understanding of this condition by educating our community members about the disease process and available treatments, with the expected benefit of improving care and, most importantly, quality of life. I am very interested in increasing knowledge with our frontline emergency responders. Bill will talk a little bit about that as a key component of this bill, and also improving knowledge of frontline healthcare professionals. Emergency responders are frequently called to assist patients who maybe have fallen at home or encounter patients in their day-to-day work who may be experiencing, our individuals and our patients, may be experiencing side effects of their medication, such as involuntary movements. Knowledge deficits of appropriate care by our health professionals often leads to delays in adequate treatment. Thank you.
Thank you. Bill Patchen, lifelong Massachusetts resident, Franklin, Mass. Thank you to co-chair Sayre and Decker for having us today. As Kathy had suggested, she has given the background on Parkinson's disease. There are more than 20,000 individuals living with Parkinson's disease that not only affects the individual, but also their entire family unit. Our goal as an organization is to provide education and resources to help people navigate through the diagnosis and through their entire life. As you may know, PD is not a death sentence, and what we try to do is provide individuals with guidance to help navigate through that. This bill will help us provide those support components to the individuals that live in Massachusetts, not only resources, but education. We've been doing this in the state of Massachusetts here as an APDA chapter since 1985. We have a grassroots approach. We have a volunteer board, and we would look to your guidance to help us navigate through the state, to help us educate and inform the residents with Parkinson's disease. We have many resources here in Massachusetts and nationally that can help provide, guidance on the booklets and education things that we can put together. And Additionally, one of the really important things that Kathy spoke about is working with the first responders. I'm a former Massachusetts first responder, and what we've done is we've created an online education portal that will allow first responders to actually go on. It's an hour to 2 hour session that will inform them about the signs and symptoms of Parkinson's disease, so that when they're responding, they can understand a little bit of the background, and that the information that they're receiving is not misinterpreted. This is very important. We've seen this bill and this certification actually implemented in multiple states in the Northeast, including New Jersey. So this program was designed in New Jersey, and we worked with Rutgers University in developing the online certification. So this is something that is really, really important to us. As Kathy has mentioned, there is a lot of cost associated with dealing with Parkinson's disease. It's our position that if we were to educate the PD population and the people around them, we can help them navigate through their diagnosis, hopefully improve their quality of life and reduce costs across the board. Thank you. That's perfect.
Wow.
Just like reiterate the comments. Thank you so much.
Thank you all. Okay, this time we're moving on to House 2182, Senate 1330, an act to reduce incidence and death from pancreatic cancer. And joining us virtually is Brock Cordero. Oh, okay. All right, welcome. I'm sorry, are you, so Brock, are you Mary Catherine?
I am.
Okay, so we'll have you both up and just, it'll be a total of 6 minutes. So just know that at 3 minutes, anything you go over after that will be in your.
Thank you.
Thank you.
Hello, my name is Brock Cordero, and I just want to thank the committee for this opportunity to testify in support of H 2182 and S 1330, an act to reduce incidence and death from pancreatic cancer. I'm a volunteer and advocate with both the Pancreatic Cancer Action Network of Boston, as well as the American Cancer Society Cancer Action Network of Massachusetts. And I just ask on behalf of all pancreatic cancer patients, their families, and their friends that you please act favorably on this legislation. This legislation would implement the recommendations of the final report of the Special Legislative Commission to Study Pancreatic Cancer in the Commonwealth, and I was honored to serve as its chair. The commission first met in February 2019 and submitted its final report in October 2019. We were comprised of 15 diverse members of various qualifications and experiences, and established with overwhelming support of both the Senate and the House of Representatives within a supplemental budget signed into law by Governor Charlie Baker. The Special Legislative Commission to Study Pancreatic Cancer concluded that pancreatic cancer is considered one of the toughest cancers faced both in the Commonwealth of Massachusetts and across the United States. This is evidenced not only by the anecdotal stories of patients and their families, but the data presented in the report. In light of the fact that the time is rarely on the side of pancreatic cancer patients and their families, I want to stress that we implore the General Court to take urgent action upon our recommendations. Chief among our recommendations is the critical need to establish awareness campaigns for the early detection of pancreatic cancer to ensure more positive outcomes for patients and their families. An act to reduce incidence and death from pancreatic cancer currently has 82 individual co-sponsors, 15 senators, and 67 representatives, many of you. Therefore, the legislation is co-sponsored by nearly or over 40% of the Senate, House, and the entire General Court. Pancreatic cancer has a 5-year survival rate of only 12%, and that statistic for a major cancer only rose out of the single digits in 2020. Over 70% of pancreatic cancer patients will die within the first year of their diagnosis. Less than 20% of patients with adenocarcinoma, the most common type of pancreatic cancer, have a surgical removal option for their tumor. Pancreatic cancer is extremely difficult to diagnose, especially in the early stages. This is because the pancreas is located deep within the abdominal cavity, and pancreatic cancer may cause only vague symptoms: abdominal, back pain, weight loss, jaundice, loss of appetite, nausea, changes in stool, and recent onset diabetes. The American Cancer Society estimates that in 2023, there will be 1,400 new cases of pancreatic cancer in Massachusetts and 1,110 deaths. Pancreatic cancer is the second leading cause of cancer deaths in Massachusetts this year, behind only lung cancer, and ahead of such cancers as colorectal, breast, and prostate. Nationally, the American Cancer Society estimates that there'll be 64,050 new cases of pancreatic cancer and 50,550 deaths in 2023. Pancreatic cancer is the 11th most commonly diagnosed cancer in America. I could list prominent figures, politicians, celebrities, but this legislation is of vital importance to me, as my father, Norman Cordero of Dartmouth, was diagnosed with pancreatic cancer in September 2013. He underwent a failed Whipple procedure at Mass General Hospital in October 2013 and died at St. Hospital in New Bedford, Massachusetts from pancreatic cancer on March 30th, 2014. My dad was 66 years old at the time of his death, less than 1 week from his 44th wedding anniversary on April 4th. Enacting this legislation will not bring my dad back, and it will not bring me any closure. However, it just may lead to a day when a child will no longer lose his parent to pancreatic cancer. With an act to reduce incidence and death from pancreatic cancer, perhaps testimony like mine will be less necessary as survival rates increase and pancreatic cancer becomes first a treatable and then someday a cured disease. Please support this legislation by reporting the bill favorably out of this committee, as it was the positive result when it was first filed in the 2021-2022 legislative session. Thank you for your time and your consideration.
Thank you so much for the opportunity to be here and to tell my story to such a distinguished audience. On the day that I was diagnosed, I Googled survival rates for women, and the number I saw terrified me. I knew that pancreatic cancer was deadly, but I had no idea just how deadly it was until I was faced with a 3% survival rate. I vowed to never Google anything about pancreatic cancer again. My symptoms started after a fun-filled weekend in Rhode Island. I started feeling off about a week after I returned home, and since it was 2020, I took a COVID test. After a negative test, I made an appointment with my PCP. I had a Zoom meeting with her where I described my very vague symptoms. I was in tune enough with my own body to know that something was off, and I was being motivated to see my compromised mother during a global pandemic pushed me to find the cause. My doctor ordered blood work and additional testing, and then referred me to a liver specialist who would later give me the dreaded diagnosis. Pancreatic cancer was the last thing that I expected to hear. I was sure that he was going to tell me to lose some weight and maybe control my pandemic drinking habits. Instead, he told me that they found a mass and that they had every reason to believe that it was pancreatic cancer. I made him check to make sure that he had the correct chart. Over the course of my treatment, I had 12 rounds of 5-FU chemo, 10 rounds of radiation, 20 rounds of oral chemo, more COVID tests, blood work, and CAT scans that I can count. I had 18 days of inpatient care and so many visits to MGH. I underwent the Whipple procedure and I missed 2 full months of work, all during the pandemic. I'm happy to report that as of my latest scans in April, I am clear and there is no evidence of disease.
Seconds.
I would thank you. I'm extremely fortunate that not only did I have access to the best medical care in the world here in Massachusetts, but I also had a supportive employer and medical insurance that enabled me to get the best possible care. Not everyone is that fortunate. My doctors told me that my cancer had been found incredibly early and that if treated aggressively, they would have every reason to believe a positive outcome. I was determined to make that happen. While undergoing my treatment, I was often asked about participating in research studies. I gladly signed up for every single one that I could. It is my belief that if something can be learned from my experience, whatever my outcome is going to be, if it will help others, I want to make sure that that happens. My first appointment with my PCP was July 29th. I was diagnosed on August 11th. My mother passed away on August 30th, and I started chemo on September 3rd. That's 23 days from diagnosis to the start of treatment. I was diagnosed, treated, and am now cancer-free faster than it's taken to get this initiative to be heard. With this deadly disease, there's no time to waste. We've all been waiting too long. Thank you so much.
Thank you for your time and thank you for taking the time to share your stories with us.
Thank you.
Thank you.
Thank you. At this time, I'm going to call for, we're going to look at House 2202. An act establishing a commission to study the encouragement of organ donation. Sean Fitzpatrick from New England Donor Services.
Good morning, and thank you for the opportunity to speak today. My name is Sean Fitzpatrick. I'm the Chief Public Affairs Officer for New England Donor Services. Testifying to provide basic information on House 2202, an act establishing a commission to study the encouragement of organ donation. By way of background, NEDS is the federally designated organ procurement organization responsible for coordinating organ and tissue donation for transplant in the 6 New England states, including Massachusetts. Federal regulations require hospitals to refer all inpatient deaths to the local OPO, NEDS, so that medical suitability for organ donation can be assessed, authorization for donation obtained, organs surgically recovered, and allocated to transplant recipients based on the national wait list. Because H2202 instructs the proposed commission to study the use of direct and or indirect monetary incentives, I thought it would be important to provide some legal background information on those topics. First, at the federal level, the National Organ Transplant Act of 1984 prohibits the buying and selling of organs from living and deceased organ donors. This law was put in place to prevent the exploitation of donors and to ensure that organs are allocated based on medical need and not financial means. Second, at the state level, the Commonwealth's Uniform Anatomical Gift Act also prohibits incentives for donation from deceased donors. And lastly, at the international level, the foremost donation and transplant organizations in the United States have all endorsed the Declaration of Istanbul on organ trafficking, which calls on governments to develop and implement ethically and clinically sound donation that is a financially neutral act. While a commission to study ways in which organ donation can be promoted and continue to increase in the Commonwealth is laudable, a focus on the types of incentives that are precluded by law already or established ethical principles widely adopted by professional and patient groups should be excluded from the charge of the commission. Thank you very much.
Okay, just the bills, some of the bills we have before us without anyone signed up to speak are House 2199, an act exempting barbershops from certain sewage flow design criteria. House 2170, an act relative to Parkinson's disease, public awareness and education. And Act 2167, an act requiring identification of food allergens and eating establishments. House 2166, we do have someone signed up for this, an act relative to local boards of health and the sale of legal tobacco products in the Commonwealth. If you are on our team's screen, it's Lisa Phillips from Tobacco Free Massachusetts. Lisa, are you with us? Okay, I don't. Right. House 2156, an act relative to enhancing statewide hospital capacity coordination. We heard from Rep. Driscoll on that. And House 2147, resolve providing for an investigation and study by a special commission relative to long COVID related needs in the Commonwealth of Massachusetts. And we have a number of people signed up for this bill as well, just to say we're going to take up to 30 minutes of testimony. And if you don't make it in those first 30 minutes, if there's time at the end, like the others, we will try to come back to you. At this time, I have Philip Chernin, who is signed up. Are you with us, Philip?
Yes, I am.
Welcome.
Thank you very much. I greatly appreciate the opportunity to be here. I am speaking in support of Bill 2147, resolve providing for an investigation and study by a special commission relative to long COVID. Thank you for holding an early hearing on this bill. The bill will establish a time-limited special commission to study and report on and establish legislative and policy priorities to address the growing crisis posed by long COVID. Several speakers after me are going to provide details on the issues and specific symptoms and difficulties regarding long COVID. I'm going to provide a general overview from the standpoint of an organization that I co-president called the Massachusetts MECFS and FM Association. MECFS is a debilitating illness that can be caused by a variety of pathogens, including SARS-CoV-2, which is the COVID-19 virus. In many respects, MECFS represents the worst case scenario for someone with long COVID because there is no known cure nor FDA-approved treatment for the illness. Early intervention in a long COVID patient offers the best opportunity to avoid developing ME/CFS, to achieve positive outcomes, reduce disease burden on patients, their families, our healthcare system, and economy. And this is why it's so important to advance this bill from committee and move it quickly to passage. While the term long COVID is new, the disabling symptoms of post-infectious chronic illness is not. Our organization has been helping patients and families for 40 years. And in this past 3 years, due to the COVID pandemic, requests for our services has more than doubled. Long COVID patients are in need of a great many resources to cope with the devastating change in their health status and its effect on their life circumstances. The most common request we receive is to help patients identify healthcare providers that have experience with post-infectious chronic illness and that are available. The long COVID clinics in the state, as I'm sure you'll hear later, and which is the case across the country, are completely overloaded. Some have wait times of up to 1 year. Not only is this devastating for patients, but it creates an emotional burden for the clinicians themselves who live with the knowledge that patients are suffering and they don't have the time or resources to help. And it's important to recognize that long COVID affects people of all races, ethnicities, and ages. There is indeed pediatric long COVID. Long COVID in youth, adolescents, and young adults causes enormous stress, fear, and anxiety for kids and their families. Our experience working with children suffering from post-infectious illness such as long COVID is that there's a very high likelihood of full recovery with early, appropriate intervention, which at this time is simply not possible. The need for trained
Thank you.
Thank you
If
very
you would
much.
like to submit the rest of your testimony in writing, we will certainly read it. Thank you.
You bet. I appreciate it.
At this time, I'd like to welcome Lachlan Foro from Harvard Medical School Center for Bioethics and Dignity Alliance. Lachlan, are you with us? Okay. At Shielding Cornoyer? Cornoyer? Okay. Michael Stein? Linda Sprague Martinez?
Hi, can you hear me okay?
Yes, who's speaking?
This is Linda Sprague Martinez. Martinez.
welcome,
sorry.
Linda.
I was like, wait.
Welcome.
Thank you. Thank you so much. I would like to thank the chair. My name is and the chairs of the committee. I'm here to provide testimony in support of House Bill 2147, the resolve providing for investigation and study by a special commission relative to long COVID related to the needs of the Commonwealth. Again, my name is Linda Sprague Martinez. I'm an associate professor at Boston University School of Social Work. I'm a resident of Boston in the Roxbury neighborhood. I'm funded by a group called the Mass CPR through Harvard Medical School to lead a group of researchers from across institutions looking at long COVID equity. And as the previous, I won't repeat what's already been said, and we'll also be providing written testimony. We recently completed an assessment of long COVID in Massachusetts. We did a long COVID landscape assessment where we identified and spoke with long COVID health providers and clinics. And we also led 11 focus groups with residents in 4 different languages, and they were all diverse Black and Latinx residents. We conducted them in Spanish, English, Haitian Creole, and Portuguese. We talked to 99 residents from across the states. They were all either experiencing symptoms, COVID symptoms for over 30 days and fit the classification of long COVID. And we heard a number of different things from them. We heard that first of all, probably the most important is that although they were experiencing symptoms of long COVID, such as fatigue, pain, cloudiness, loss of stamina, hair loss, and others, they hadn't heard the term long COVID. They didn't realize that it was a diagnosis, long COVID, and they were often dismissed by their medical care providers. This had mental health implications in terms of wondering what was going on with their body, and just additional stress for them. We heard from people who had been out of work. We have heard from people who had to sell cars to meet their debts as a result of being out of work for symptoms associated with long COVID. And we've also heard from challenges of not having paid time off and what that meant for long COVID, because they had to, it's not just one medical visit, it's multiple medical visits when they could find care. So with all this, and we're submitting written testimony as well. We think that the state does need to have a commission on long COVID. There are a number of long COVID resources and research studies that are happening in Massachusetts right now. They're all on the eastern part of the state. When we looked at the resources that were available across the state, we saw that there were gaps in Western Massachusetts and even in counties that were highly hit by COVID-19, such as Hampden County. There were no resources. And as the previous person said that, sorry, I'll stop.
Thank you.
Yeah.
Yes, thank you very much. And do feel free to submit your written testimony as well. I see that Dr. Lachlan Faro has joined us now. Welcome.
Yeah, sorry, I apologize for not being able to respond
That's okay.
immediately to get my camera on. So my name's Lachlan Faro. I'm speaking to you now in strong support of this bill. From my experience for 2 years, from 2009 to 2011, as chair of something called the Massachusetts Expert Panel on End-of-Life Care, which was established by the legislature and had experts from across the Commonwealth at a time when that topic, end-of-life care, was maybe the most polarizing topic in the country. You remember allegations about death panels and lies and people saying you can't talk rationally about this. Thanks to the work of the members of the panel, including Senator Pat Jalen and many others, what that panel accomplished was creating a roadmap that everyone in the Commonwealth agreed outlined the issues fairly and clearly, the work we needed to do. Many things grew out of that, including the establishment of an advisory council to the Massachusetts Department of Public Health on palliative care that I chair, the Massachusetts Coalition for Serious Illness Care, and other things. And I want to stress in support of the powerful testimony from Representative Dama and others, not just the importance of this, but the urgency of this bill being passed as quickly as possible, given the deadline in the bill, which I fully support, of its initial report and recommendations of March 1st, 2024. Because currently in the Commonwealth, as we all know, whether the topic is masking or safety or dangers, or we do not have a vehicle for the people of the Commonwealth and our state and government leaders and medical experts to come together and think systematically about all the challenges of COVID, which affect so many aspects of our lives. And the sooner this commission can get to work, the better. I think there are lessons from the success of our expert panel end of life care that would be applicable, and I'm very eager to help. So thank you for this, and I hope the committee will recommend this quickly and the legislature can approve it so we can get to work in a unified way across the Commonwealth rather than in the currently less productive fights people are having without the issues even being clearly defined.
Thank you. Thank you. At this time, I would welcome Ellen Lee. Ellen, are you with us? Okay. Susan Barney. All right. That is who I have signed up for House 2147 at this time. On the docket for review today is House 2130, an act protecting the health and safety of people in restaurants. We have no one at this time signed up. House 2125, an act instructing the Massachusetts Department of Public Health to study the feasibility of absorbing oversight of all memory care, assisted living facilities, and units in the Commonwealth. There's no one signed up today to testify on that bill. House 3631, an act expediting the diagnosis and treatment of certain infections. Again, there's no one signing up. Just for the public's knowledge, even if no one has signed up, that does not mean that we have not received testimony both from the bill filers and from those who support or who oppose the bill. At this time, we're going to start with House 2204, Senate 1334, an act relative to accelerating improvements to the local and regional public health system to address disparities in the delivery of public health services. Again, we're going to take, because the large number of people have signed up for this, we're going to take up to 30 minutes of testimony. And then if we have time at the end, try to weave the rest of the speakers in with other bills that have gone over the 30 minutes. So at this time, I'm going to welcome Chelsea Patrice from the Health Equity Partnership. You're signed up on Teams, I believe. Okay. I'm going to welcome Effie Acom from the Harvard School of Public Health. You should be here in person. Okay. I'm going to go back to our teams. Glenn Ayers, retired health and Glenn Ayers.
Hi, good morning.
Welcome.
Thank you. Good morning, Chair Siren Decker and committee members. Appreciate the opportunity to provide these comments today in support of passing S1334H2204, also known as the SAFE 2.0 Act. I'm a retired regional health agent for Franklin County. I'm currently serving as a subject matter expert working with the Mass Health Officers Association on the statewide public health excellence survey effort of every community in the state. Prior to retirement, I was a state registered sanitarian, a certified health officer, a certified public water supply operator, a certified municipal wastewater treatment plant operator, a certified lead paint determinator, certified Title V system inspector, a DEP approved Title V soil evaluator, and I maintained numerous other public health certifications for my job. And I'm not saying all of that to brag, but to highlight the highly technical nature of public health in Massachusetts, especially considering the antiquated public health system that we have that relies almost entirely on volunteer boards of health. And providing the technical expertise to those boards is critical to our public health delivery system in Massachusetts. The proposed legislation, the SAFE 2.0 Act, would revolutionize this public health delivery system and ensure that a qualified workforce supports our local boards of health by providing essential technical expertise based on professional credentialing. And I know this is necessary firsthand from working in the trenches with more than a dozen towns in the most rural county in Massachusetts, Franklin County. This bill in the previous session was passed unanimously by both chambers, only to be vetoed by Governor Baker, which in my opinion was a travesty. And I really encourage you, implore you, hope that you will quickly pass this bill out of committee and bring it to Governor Healy to sign. It is long overdue to have this happen in Massachusetts. I thank you very much for the opportunity to provide testimony, and I will follow up with submitting written testimony as well.
Great, thank you. Are there any questions from the committee? I do want to note that I believe my understanding is 311 municipalities in Massachusetts are already engaged in service sharing agreements, and over $200 million of Massachusetts dollars are being spent on this effort. And as you accurately stated, this was an effort that was passed by the legislature and meddled with by the prior administration, but hoping we can fix that. Next, we have Julie Boras from Health Rights Mass. Sorry if I'm butchering your name.
I'm one of the founders of Health Rights Massachusetts, and I'm here today to testify on behalf of our membership of over 13,000 Massachusetts residents and growing. Of course, we think it's a great idea to always be improving public health here in Massachusetts, and we recognize that as the goal of H2204 and S1134, and we appreciate this must be a difficult task. Our interest is to ensure that the individual rights of Massachusetts residents to control their own bodies and make their own health decisions are protected. We are also very concerned about transparency in the process around how public health policy decisions are made. Given the recent history of coercive medical treatment in Massachusetts and its impact on our daily lives, employment, and educational opportunities, we have serious concerns about this legislation being proposed to create public health excellence in the Commonwealth. We want to make sure that these changes don't infringe on the rights of people to make their own health decisions. It's the opinion of Health Rights Mass and its members that the governors never really should have been granted such broad powers during a public health emergency. I'm certain that the lawmakers that passed those laws way back in 1965, expanding emergency powers to broadly include public health, didn't realize the ramifications of how those powers could be abused in the future. And they were abused badly. There's an ever-growing lack of trust in public health, starting at the top with the CDC and the FDA and working its way down. The FDA asked the courts to hide Pfizer's COVID-19 clinical trial documents from the public for 75 years. Ask yourself why, and then why should we trust them? As to the bills themselves, the language is very broad with no protections written in for privacy. These bills seem to take away autonomy from local boards of health and give more top-down government control. If municipalities take this grant money, which they have, then they will be required to comply. Comply how? Would this apply to lockdowns, schools and business closures, testing, tracking, and tracing, masking, social distancing, and vaccine mandates? It's unclear. This bill aims to educate a new generation of public health care workers based on national standards, but I was unable to find any information regarding the curriculum itself and want to know if this will be made available to the public. Lastly, this bill once again ignores the public health elephant in the room. Vaccine injury is a public health crisis, and the vaccine injured are ignored and censored and gaslit. Really?
Thank you. Yes, you have 3 minutes. You're welcome to submit the rest of
Okay,
your testimony.
Questions?
Thank you. At this time, I would like to welcome our former colleague and now Mayor Broder from the great city of Melrose. Thank you, Mr. Mayor. So, Mr. Broder, Mayor Broder, sorry, we usually unmute when we want to be heard. If you could try that.
I am delighted to hear, Madam Chair, that you have the decency to feign interest in what I have to say. That is very exciting
I've
for me.
always done my best with you.
And Mr. Chairman, it's good to see you and the members of the committee as well. Not to be redundant, but I was before you all, I believe, either in writing or with oral testimony last session about the importance of advancing progress in local public health through SAFE 2.0. But it is good government. It's about efficient delivery of services. And I will speak from the experience of being a COVID mayor and to my current and former colleagues, in particular Lieutenant Governor, that really recognized in practical terms how effective local public health efforts are, not just in terms of the need to be nimble on the ground, but to also have a prevention role and the opportunity to cooperate and share those best practices and take the best of what your regional partners have to offer is just critical. Because to a certain degree, we learned a lot of lessons through COVID, but I guess I would note that maybe different, in a little bit of a different context than what the last speaker was talking about. We need to take those lessons and learn what to do and how to best react to the next public health crisis, but also to recognize all the other things that good public health is all about. I know you all know this because this is the work that the members of this committee do and tap the expertise of folks to do, but the need to incentivize cross-jurisdictional partnerships is really critical. And that sounds like a bunch of mumbo jumbo, but it really is about leveraging what works and leveraging that expertise, because whatever the health challenge is, we know that health outcomes aren't driven by what happens when you get to the hospital or your primary care, down to a certain degree, but the best work in public health is making sure, to the extent we can, we avoid those situations in the first place. It's good policy, and it's good in the long run for lowering the cost of healthcare overall, which we know, not to bring out that cliche, we desperately need to shift from treating the sick to focusing on good health practices and good health outcomes to avoid a treat the sick model. So really, SAFE 2.0 is that roadmap. It is the way to get to a better place. And honestly, it is to, for some communities, it's an opportunity to upgrade. We know we started to a certain degree with the way we did VSO services, where it used to be a somewhat unregulated world. We recognized when I was in the legislature, there were some deficiencies there, and we needed to set some minimum standards to make sure that all the hard work around making sure benefits are delivered and that the diverse needs of our veterans were being met was helped along by this standardization. This legislation will include benchmarks to make sure that local public health is meeting the mark. And regrettably, there are many communities that are not meeting some of our regulatory and statutory standards. And this would require DPH to make sure that that happens. So yes, it's a money investment, it's a policy investment, but ultimately it is making sure that every community in the Commonwealth is delivering a benchmark level of public health services that, again, that are going to go to, as more importantly than anything else, care and prevention. So with that, again, I wouldn't presume to speak for my other mayors, but I do know this particularly. I am the head of the Metro Mayors Coalition, which is kind of an inner core of mayors and town managers, plus Melrose, which is a little bit more suburban, but this is a critical long-term priority to make sure that we are turning to a much more proactive, positive model of delivery of public health. So with that, I will absolutely thank you for your time, and happy to answer any questions, but I know you have folks that have a lot more wisdom than me that are in the queue, and I don't want to take away from their time.
Thank you, Mr. Mayor. That was riveting. Would only
No
be better
doubt.
if you were here in person. So we really appreciate your work and your leadership in the city of Melrose. It's good to see you.
Pleasure's mine. Thank you all very much.
At this time, I would welcome Shin Yi Lau from the Newton Health and Human Services Department. Okay. I'm going to welcome Elizabeth Ogilvie from the Springfield Food Policy Council. And I just want to acknowledge Senator Comerford, who's been a terrific leader in the Senate on this, and my former co-chair has also joined us and has been, we clearly know where her support is, so thank you for being here. So we have Elizabeth Ogilvie. Okay. Going to jump over to Norris Guscott from the Lynn Department of Public Health. Okay. At this time, going to welcome Dr. Gerald Green. Are you with us on Teams?
I hope so.
Welcome.
All set. Chair
All
Decker, Chair Sear, and members of the Joint Committee. Thank you for the opportunity to address you today. I am speaking obviously in support of H2204 S11334. My name is Dr. Gerald Green, and I am the chair of the Aquinnah Board of Health, a member of the Inter-Island Public Health Excellence Collaborative, one of the original 14 grant holders in the Public Health Excellence Shared Services Program. Our group predates COVID by several months and was a vital factor in the fact that the islands had among the lowest COVID rates in the Commonwealth, notwithstanding a steady influx of tourists throughout the recent pandemic. I am a retired Massachusetts physician who for almost 40 years served as a Massachusetts state tuberculosis consultant, and I am quite familiar with our many public health challenges. As chair of the Board of Health in one of the most underserved towns in Massachusetts, I would like to stress the importance of sustainability of the funding and the need for an underlying roadmap to the most efficient expenditures of those funds in the SAFI 2.0 legislation. Aquinnah has 691 residents. Only 13 towns in Massachusetts have smaller populations. We have approximately 30 families living on Wampanoag tribal land and approximately another 100 members of the tribal nation living within our town. Our town budget is approximately $6 million. Our Board of Health office has one employee who is a 15-hour-per-week health agent. While our inspections are augmented by our Excellence Grant Group's shared inspector, our unpaid, strictly volunteer board members find themselves called upon to do tasks that you as legislatures never would have intended board members to do. For instance, our town has no public water supply, so our members have often served as Title V inspectors and restaurant inspectors. We do not have the resources for alcohol and substance abuse and mental health monitoring and intervention. When our previous health agent quit unexpectedly, I wore many hats until a replacement was found 4 months later. Under the Excellence Grant, our volunteer members occasionally functioned as if they were the paid trained agent. Another town in our collaborative spends the same percentage of its town budget on its public health functions. Instead of only one very part-time employee, that town has one director, an administrative assistant, a special projects administrator, 4 full-time inspectors, an environmental contamination administrator, community health clinic administration, and a public health nurse. One town, ours, has 0.375 FTE, another with 10. We definitely support SAFI 2.0. Thank you.
Thank you. Okay.
A comment, just really thrilled that I represent Aquinnah, of course, almost the most furthest flung community in my district. Gosnell's a little further flung, but really just want to appreciate and recognize this hybrid format where we can have committee hearings. If Dr. Green were to travel here to the State House, even without even not considering the current bridge traffic we have, it would take quite a bit of time. So this really allows Islanders and other people from the hinterlands in Massachusetts to be participating in our legislative process. I want to thank Dr. Green for being here and just really laud us for having this option.
Thank you.
At this time, I would like to welcome Lynn Greenwood. I hear you are here in person. Welcome.
Lynn Greenwood, and I'm also one of the founding members from Health Rights Mass. Last fall, Mike Hugo, the director of policy and government relations at Mass Association of Health Boards, he presented data regarding the Public Health Excellence Grant at our Board of Health meeting in my town. My main concern with the grant is if the town chooses not to sign on, they will not receive access to the $200 million of federal ARPA funds, which to me just doesn't seem like it's fair. So that's on that. In conjunction with this, almost half the $200 million is designated for data systems and performance tracking. There should be some clarification, I think, at the community level, what that means and what it means to the Board of Health and what it means to the constituents of that community. Mike Hugo referred to it as free money. But as my high school economics teacher, Mr. Berman, told me, and ingrained in my brain, that there's no such thing as a free lunch. So it just, I get concerned when I hear free money when it's in regards to tracking and tracing. The one big thing I want to raise, data integrity. To invest almost $100 million in data tracking and not step back and look at the tools being used to collect data, I think is like throwing money out the window. I feel strongly. There's a lot of talk about Lyme disease today. I'm a Lyme disease survivor. 6 months I was completely disabled, extreme pain, fatigue, no muscle. I couldn't lift my arms. I couldn't pick up a glass. I couldn't walk. I couldn't do anything for 6 months. My PCP in Boston tested me for Lyme and arthritis. I was negative for both and was told there was nothing wrong with me. So I cured myself outside the mainstream medical system. I'm 100% cured. I'm very proud of that. And I'm a different person today because of the experience that I had. Rarely do people test positive for Lyme, and most end up being turned away by the medical community. There's a documentary that came out called The Quiet Epidemic, and it's being released online on May 16th. So I'm going to try to forward you the committee some of the data in that documentary because it was amazing. It brought up serious concerns about the integrity of the Lyme test. So I never tested positive. Most people don't. So the other, the PCR test, we know at this point that anything over for COVID that was over 35 cycles is even Dr. Fauci said was invalid. It was a negative. It was what do they call false positive. So those are just two examples of just poor integrity. So if we're doing data tracking, I pulled on the CDC website last night, the state of Massachusetts for the past 10 years. Up until 2016, there was anywhere from 3,000 to 5,000 cases of Lyme, and for some reason, the past 4 years, it's in the single digits. I mean, I had 3 people, and there's 7 people in 2019, and I knew 7 people in my community that had Lyme. So just an idea of the data integrity issue.
Thank you for your testimony. At this time, I welcome on our team's screen here is Mayor Gina Louise Sierra. And if I'm not saying that last name, please correct me.
It's Shara. Thank you so much. And thank you for the ability to do this remotely. I'm not coming quite as far as from Aquina, but out here in Western Mass, this makes it much easier. So thank you. Good afternoon, Chair Siren Decker and honorable members of the Joint Committee on Public Health. Thank you for the opportunity to address the Joint Committee today in support of H224 and S1334. As the mayor of the city of Northampton, I am keenly aware of the fact that diseases and other public health challenges do not stay within municipal borders. Having someone living in a town nearby whose community does not fund public health nursing, since there's no current state requirement to do so, they may come to Northampton to work, eat, play, and spread an infection despite our own very well-staffed Department of Health and Human Services. As the urban center of a largely rural county, Hampshire County, Northampton works hard to initiate and support regional public health solutions to issues as diverse as opioid use disorder, youth substance use prevention, and communicable disease response and surveillance. During COVID, our small health department staff was called upon to serve as contact tracers for many of our neighbors, and we continue today to host a public health excellence grant providing regional public health nursing for a total of 14 towns. We're able to bring vaccination, health education, and disease tracking to isolated towns like Middlefield or Plainfield that, with populations well below 1,000, simply do not have the resources to provide those services. Our regional collaboration shows great promise, but its future is dependent on the passage of the SAFE 2.0 bill. The bill is long overdue for Massachusetts, where our inequitable system has resulted in neighboring towns having vastly differing protections for their residents, meaning a single zip code can determine the future of someone's health. I know you've received a letter with more than 100 signatures from my fellow mayors, select board members, town administrators, and boards of health across Western Massachusetts. Thank you very, very much for heeding that call for a speedy hearing by scheduling the bill today. We're thrilled that the bill passed the House and Senate unanimously last session, and we hope that we can repeat that success very soon. Again, thank you so much for your time and for your ability to come and present this to you in this way.
Thank you. And at this time, I would call Sterling Smith. Are you with us? Okay. Going back to Barry Keppard from the Metropolitan Area Planning Council. Welcome.
Thank you. Thank you very much. Thank you, Chair Decker. Thank you, Chair Sear, and members of the committee. Appreciate the opportunity to offer our support for H224 S1334. My name is Barry Keppard. I'm the Public Health Director at the Metropolitan Area Planning Council. I'm here today on behalf of MAPC and the Massachusetts Association of Regional Planning Agencies, or MARPA. MAPC is the regional planning agency for the 101 cities and towns in Metro Boston. We prioritize efforts that foster regional collaboration. Throughout the pandemic, MAPC, as well as our sister regional planning agencies, were deeply involved in helping our cities and towns navigate both the direct and indirect impacts of COVID-19. We remain committed to ensuring that our planning work addresses critical public health needs across our region and seeing that same thing happen across the Commonwealth. In our work and in many of the others' work, we center social determinants of health and partner closely with the cities and towns to integrate a public health approach, not only in the local public health work, but also in other aspects of planning, policy, and project work. Definitely want to recognize and appreciate your leadership on the SAFE Act, which was signed as Chapter 72 of the Acts of 2020, and the investments dedicated to local and regional public health in Chapter 102 of the Acts of 2021, which allowed for the deeper coordination and facilitation of local and regional public health across the Commonwealth. We're really grateful to the committee and to the legislature for the passage of this legislation last session and look forward to hoping to get it across the finish line in this session. Demands on local public health boards and staff were growing even before COVID-19. Staff and resources have long been strained trying to meet these vital responsibilities in the context of limited resources, as we've heard references earlier, local support, and community awareness of the work. And so as we emerge from the pandemic, public health practitioners have asked us to further extend the breadth of the work, and I think that's reflected in SAFE 2.0. The policies of SAFE 2.0 are really to support baseline essential public health protections. Just to give you a flavor, I think as other people have spoken to it, we've seen the work catalyze new potential in Chelsea, Revere, and Winthrop in terms of public health nurses being able to offer childhood immunization services that weren't present there before. In places like Foxborough and partner towns that are now doing kind of consistent practices around food inspections. So again, if you're opening a restaurant looking for those protections, it's happening across a wide swath of area. And we're also seeing it in areas like the North Shore, where people are essentially meeting those housing inspectional services more frequently. So what that means is that people are living in a high quality, healthy indoor environment. We see similar efforts happening across the nation, and it'd be great to have Massachusetts be at the forefront and be that standard for public health excellence. The SAFE 2.0 Act includes common sense changes that will better prepare Massachusetts public health infrastructure, not only to meet the moment, but for future public health crises. We look forward to your support of this. Both MAPC and MARPA have submitted written testimony, and we look forward to your continued support of the critical legislation. Thank you for your time, and thanks for the audience with you today.
Thank you. Okay. At this time, I'm going to take a panel, and I will welcome Melanie Ames Zamachski. All right. If it's not good enough, tell me. And Phoebe Walker, welcome. You also have traveled far today.
Don't even ask us where we parked. We don't know. Do you want to go first? No, you. Okay. All right.
I just want to remind you, because you're up here together, you have 6 minutes, so I don't want you to feed into each other's time if you don't mean it.
We practiced it in the car. We're good.
Perfect.
Okay.
Yeah, good. Long time to practice.
Thank you. Good morning, Chair Decker, Chair Sear. Wonderful to see you, Rep. Kane, and all the rest of you. I really appreciate your time. I'm here representing the Franklin Regional Council of Governments and the Western Mass Public Health Association. At the Council of Governments, we're the host to a 15-town rural health district that serves a very small population over a very large area. And the Western Mass Public Health Association is the group that sent you the letter with all the sign-ons that the mayor just referred to from Western Mass. So I also, from 2016 to 2019, served on the Special Commission for Local and Regional Health, whose report, the Blueprint for Public Health Excellence, identified the urgent need for the bill that's here before you today, the H2204 S1334. So the thing I mostly wanted to talk about today was the great importance of this bill to the 171 rural communities in Massachusetts. I think we've heard from other folks. Rural towns cover about 60% of the Commonwealth's land, but only less than 15% of the population. And the governments of these towns really struggle with limited water, sewer, broadband broadband infrastructure, limitations on commercial activity, mean that these communities have a lot less to spend on local public health. And as our state today, as I know you know, is one of the only one in the nation that has no standards for local public health performance and credentials, this means that there are vast inequalities in the protections in Massachusetts. Rural communities, as you may know, are barely able to fund schools, fire, and police. And without the standards and the funding that's in this bill, many are either unwilling or simply unable to fund high-quality local public health. And these inequities end up costing the Commonwealth a lot of money in both health outcomes and life. As you may know, as an example, DPH requires local boards of health to track about 70 diseases. There's no enforcement of this rule, however. So that meant that during the pandemic, this patchwork we had resulted in more than 200 communities had no regular public health nursing staff. We needed them, remember? And we had to build and then dismantle a $160 million program, the Contact Tracing Collaborative. Thank goodness we had it, but that's $160 million that could have been invested in shared staffing that would still be working today on anaplasmosis, pertussis, hepatitis, Lyme, as other people have talked about. If this bill had passed before the pandemic, we would have been so much more ready. In summary, H2204 S1334 would ensure A, all towns have access to important public health training near them. B, it would make funds available to towns to share the qualified staff and offer more efficient and effective services. C, would incentivize towns to meet the workforce credential standards that our special commission identified as really vital to the health of the residents of the Commonwealth. So the bill, combined with the millions of dollars of ARPA and state funding available to support it, would meet all the recommendations of our special commission and finally bring our state into the 21st century. So thank you for bringing this urgent bill forward for an early hearing. And over to you, my colleague.
Thank you. Good morning, and thank you for, I'm honored to be here today to speak and offer my support to the SAFE 2.0 Act. As a paramedic and now as a nurse in Western Massachusetts for more than 35 years, I've seen firsthand the impact that public health initiatives have had on our communities, especially in the underserved areas in our rural communities in Western Massachusetts. The SAFE 2.0 Act is a crucial piece of legislation that will provide strategic resources and funding for these critical programs. I've had a keen interest in public health over the years and its impact on my own community, and I currently sit on the Board of Health in the town of Montague. It's a town of just over 8,000 people in Franklin County. Once the pandemic struck, I knew that the community members didn't have enough information to try to protect themselves or their families. And in my town, we did not have consistent coverage, messaging, or control to manage the situation. And we had extremely limited hours for our public health nurse, and only a portion of that was allowed for contact tracing. While I was already contact tracing with the Franklin Regional Council of Governments, it was also vital that as a Board of Health member, that I also needed to pitch in, and I helped contact trace in the town. There wasn't any mechanism at that point that allowed any collaboration between the two municipalities in Franklin County in Greenfield or Montague. And the next town over didn't have the same rules or guidelines that we had. I cannot underestimate the effect of consistency in public health. I spoke with one gentleman who had had a severe respiratory disease, and he also contracted COVID. I followed up every day with him. I had the ability to call him and check in on him. He didn't get any better, but because I was there to call him consistently, I also recognized when his breathing changed and he needed more help than he could get at home. And at his request, I called his son, and I also called an ambulance to transport him to the hospital. When he came home, and he did come home that time, I followed up again to make sure that he had what he needed to at home in terms of services and help he needed. And while this gentleman was called, not everybody was in our town, even with the CTC. There just wasn't the time or the people to do the work. It should not be different when somebody goes 2 miles into another town to go to work and then comes home, stops for a couple of groceries, and there's a whole new different set of rules in this particular case. Consistency matters. And as a nurse, my decisions are based on science and evidence, and we need to develop the evidence and data that the bill will fund. Thank you. Thank you.
For me to have a lovely recollection of my time at the book mill. Many lovely times there.
Beautiful place.
Exactly. Thank you. At this time, we've gone over the 30 minutes we've allotted for the SAFE bill. We will come back to everyone else, but we're going to go back and alternate between other bills that have also had a number of people that have gone over 30 minutes. I'm going to welcome Senator Oliveira, who's also here waiting.
Please join me. Thank you for taking me out of turn to go back. Words in your agenda, looking at a bill that I had filed along with my colleague in the House, State Representative Ted Phillips. I'm here today to speak on behalf of my bill, an act assessing healthcare access. And I know that you have already heard from the Mass Nurses Association, who is also joining in supporting this bill. As you know, and Senator Sear, you know as well, health disparities and regional equity is a major focus for healthcare access in the Commonwealth. My area of the Commonwealth, Western Massachusetts, as you've heard from previous speakers testifying on other bills, lacks a lot of the basic services that we take for granted here within the city of Boston. So my bill will look at actually directing DPH to go and do a study of healthcare access in the Commonwealth on a whole scale level, looking at the inequities that we see on a regional level, whether you're in Western Massachusetts or the Cape and the Islands or the Merrimack Valley or the Berkshires. This bill will take a wholesale look at healthcare access. Currently in Western Massachusetts, there isn't a single adolescent youth mental health bed in the 4 counties of Western Massachusetts. I've worked with constituents when I was in the House and now in the Senate who have children that are placed over an hour away on the other side of Worcester. And if you have transportation access issues, it's nearly impossible to even visit your children. So I'd ask that the committee favorably report out this bill so we can look at the inequities in our healthcare system here in the Commonwealth to ensure that every region and every resident of the Commonwealth has access to the services needed in order to improve their health. So thanks again, Madam Chair, Mr. Chairman. I'm happy to answer any questions that you might have.
Thank you very much.
Thank you. Thank you.
Okay, so at this time, just so folks know what's happening here, I'm going to go I'm going to start with anyone who hasn't been called and still wants to testify. And then I will try to go back to everyone else who might have been called but wasn't available when we call. And I believe I did miss Dr. Nagy, who was here soon after I calling. So I will go back to Dr. Nagy if you are still here. Dr.
Yes,
Lisa
I
Nagy?
am.
Okay,
I
well,
am. I'm trying to hit video. Oh, it worked. Hi. So can you hear me and see me?
we can hear you. Welcome.
Okay, so I'm thrilled to be able to speak. I'm going to be very succinct. Unfortunately, when I looked through, I'm here for the EHS bill, electrical sensitivity, but I see that there are 7 other bills. So I'm just going to mention the topics and you can apply this statement to them. Diabetes, Alzheimer's, Parkinson's, public health, the COVID long haulers, food allergies, and I will get started. So actually, in terms of long haulers, I'm going to say it right now. I have a medical society resolution as a delegate to the Massachusetts Medical Society on long haulers COVID this week on measuring the heart rate of people in the medical office and doing a public health campaign because we have tens of millions of largely women, says the Washington Post, with postural tachycardia. And so I'm just going to say that's a big deal. And I would like to work in that area with you guys. But anyway, EHS is real. And of course, we have to document it. I'm an emergency physician that graduated from Cornell Medical College. And I specialize in the social determinants of health. I'm an activist nationally on the congressional lawn with Jon Stewart for the PACT Act. Trying to get into the White House with a team of integrative and environmental physicians to look at the cause of disease, thereby saving healthcare billions in Medicare. So I chaired the first national meeting on electrosensitivity in 2019, where hundreds of physicians came to the meeting to learn how to identify electrical intolerance and how to treat it in patients. Hundreds of people participated, and we've had that meeting every year since. And as I mentioned, I'm a delegate in the Medical Society.
Nagy, I'm going to interrupt you for 1 second. I just want to note that you had signed up for an earlier bill. And so any bill that you want to speak on, we'll give you your extra time here. You only have a total of 3 minutes. So
I know, I'm going fast. Yeah, I just covered the long haulers to mention. So the Medical Society 2 years ago passed a resolution that I had written, whether cell phones are safe. It's a big deal because all the physicians in the society, because of the Havana syndrome being accepted, agreed that they wanted to have assessment of Wi-Fi and 5G health safety. That's all the physicians at the Medical Society. I organized a panel on stage at NIH, 6 people speaking about electrical sensitivity and the dangers of radiofrequency radiation. I was on that committee for a decade at NIH on building and health. I said on a TV show, do not wear the cell phone on your body. That was the doctors. And Dr. Phil, of all people, stated that I'm probably the leading physician in the country on this topic. So hopefully my words have some clout. Better Call Saul is one of the leading cable shows, on Netflix, and it's about an electrically sensitive lawyer. He's in court stating he has electrical sensitivity. So this is accepted by the public, and we need to make Massachusetts obviously up on measuring the number of people with it in order to then mitigate their illness. I fortunately got better, and I'm no longer electrically sensitive, but I would suggest to not use a cell phone to your head and use an air tubing headset that they now sell in airports. Thank you very much.
Thank you. Seems like you spoke on the bill you meant to speak on.
Yeah.
Not the one you signed up for, though. So if you have any other written testimony, feel free to send it. At this time, I'm going to go back to a panel that I'm going to welcome Cheryl Bartlett from the Greater New Bedford Community Health Center and Bill Murphy from the Framingham Department of Public Health. Are they not here? Okay. I then will welcome Omi. Omi, if I don't get this right, please do correct me. Omi Amarasingham and Cheryl Sbarra.
Good afternoon, Chair Decker, Chair Sear, members of the Public Health Committee. My name is Omi Amarasingham, and I'm the Deputy Director of the Massachusetts Public Health Association. I'm here today in strong support of H2204 S1334, known as the SAFE 2.0 Act. Thank you so much for bringing this urgent bill forward for a hearing today. This bill seeks to ensure that all residents, regardless of race, income, or zip code, have access to high-quality public health protections. Unfortunately, this is far from the case today. The reality is that our local public health system is quite simply broken. Too many communities have poor or non-existent public health services. Rural communities, gateway cities, and low-income communities of color are most likely to go without needed public health protections, which only exacerbates the health disparities that this committee is so familiar with. Even before the pandemic, our local public health system was in crisis. But the arrival of COVID truly exposed every inconsistency, inefficiency, and inequity across the system. The result was preventable illness and death, along with extraordinary cost. But the good news is the solutions are at hand. There is quite literally a blueprint to improve this system. The Special Commission on Local and Regional Health, established by the legislature in 2016, brought together all the major stakeholders, and they unanimously adopted both a stark assessment of the current system and the blueprint for how to fix it. Some important pieces of this work are well underway. We are extremely grateful to the legislature for allocating $200 million in ARPA funds to support fundamental fixes to the local public health system that will last for generations. In addition, for the last several fiscal years, the legislature has allocated state budget funds to help communities expand capacity and make critical system improvements. And just 9 months ago, the House and Senate voted unanimously to pass this very bill, but unfortunately the bill stalled in informal sessions. So in some sense, we are here today to tie up loose ends. After experiencing a worldwide public health crisis unlike anything in our lifetimes, and with the remaining federal and state public health emergency orders set to expire next week, we must take the next step in shoring up our public health system to ensure that we are ready to meet the public health challenges of today and tomorrow. With that, I'm pleased to turn it over to my colleague, Cheryl Sbarra, to speak in more detail about where we've been and where we're going.
Thank you, Omi. Good afternoon, Chairs Decker and Sear and Vice Chairs and committee members. I am the Executive Director and Senior Staff Attorney for the Massachusetts Association of Health Boards. We are a membership association representing the 351 local boards of health in the Commonwealth. Much like police and fire, boards of health derive their legal authority from the power of the Commonwealth to protect the health, safety, and welfare of its residents. Historically, local boards of health have performed their statutory and regulatory requirements with no state funding. The pandemic was a brutal wake-up. In FY20, the legislature passed Chapter 111, Section 27D, which established a public health excellence program to encourage boards of health to adopt practices that will improve the efficiency and effectiveness of the delivery of public health services. The law was enacted in order to elevate performance standards, increase the sharing of public health services, improve data collection systems, and increase education and training for public health officials and staff. Currently, there are 319 cities and towns participating in 51 public health excellence collaboratives, with the goal of indeed improving the efficiency and effectiveness of the delivery of public health services in this Commonwealth. The Department of Public Health is well underway in creating a unified data collection and reporting system. DPH is also creating training hubs and subject matter experts in all regions of Massachusetts, and also they have completed a baseline capacity assessment. In short, the operating room is ready for the major surgery our local public health infrastructure needs. SAFE 2.0 is that major surgery. Its passage will ensure that every resident in Massachusetts has access to minimum public health standards, regardless of where they live, the color of their skin, the amount of money they have, or the language they speak. The bill will put into law and codify the goals and objectives we have all been working toward, especially this distinguished and committed body. We do not want to lose the progress we are making and continue to make in delivering public health services in Massachusetts. Passing this bill ensures that we won't. In 2006, the Massachusetts Supreme Judicial Court stated in the American Lithuanian Club versus the Board of Health of Athol case that, in quotes, the focus of public health is to protect the health of every member of the community, unquote. Passing this bill will do just that. We have set the table. Now let's serve the same meal to all residents of the Commonwealth. Thank you.
Thank you. Thank you. Okay, I'm going to pivot back to House 2158. To folks who've not been called up yet, we have some more time, so we will get through as many as we can. Alison, let's see, Alison Stafford McDonough. If you're putting a sign up on this team screens, there's no need. We have a list, you're on the list, and when we call you, we'll get there. There's been a lot of people on this bill, so if we can get to you, we will, and that's what we hope to do. You can also, for anyone else, please submit written testimony. That, I promise you, is also read by chairs and committee members. I'm going to ask Alison Stafford, are you there? Okay. Nina Anderson. Jodi Nelson, Californians for Safe Technology. Shannon Cavasos.
Yes, I'm here.
Welcome.
Hi, thank you for having me. Thank you again for having me here today. My name is Shannon Cavasos. I'm a studying building biologist in electromagnetic radiation. Today, I will be speaking about my EMS in support of Bill H2158, because this bill will help to set the precedent for other states. I'm coming to you as a victim and not just an advocate. I would like to start by summarizing statements made by Dr. Magda Havas, PhD, who's devoted much of her life's work to EMS and electrosmog. She noted that we all have electrical sensitivity. None of us, none of our bodies are unaffected by man-made EMS and wireless radiation. It is affecting us all on a biological level to some extent, whether we realize it or not. The electrically hypersensitive are the alarm bells in society, if you will. They can sense these environmental stressors where others cannot. Others who cannot may someday, unfortunately, present their symptoms in the form of gliomas, cancers, and autoimmune diseases. My journey with EMS started in 2020. I began experiencing debilitating fatigue that made it nearly impossible to get through an 8-hour workday. Like a majority of the population, I used many smart and wireless devices, both for my job and personal life. Then in 2021, I began experiencing debilitating muscle spasms in my back, requiring injections. My right arm and hand started to go numb. After that, intense burning sensations in my arms and legs made it impossible for me to sleep. I'll add to this the sudden onset of anxiety and panic attacks, neither of which I'd ever had before. I had to leave my job. These are just a few of the symptoms I had. I went to cardiologists, rheumatologists, neurologists. I had nerve tests, coronary CT scans, brain MRIs, spinal MRIs. No doctor was able to help me. Everything came back normal. It wasn't until I was introduced to a building biologist who came to my home and did an assessment that I found out I had high wireless radiation levels in my home. She advised me to get rid of my smart meter, quit using my cell phone, and hardwire my internet just for starters. Guess what happened? Day by day, I began feeling better. Although there have been some lasting effects, such as my EMS, most of my pressing symptoms have gone away. But I now have to live my life in a bubble away from EMFs and wireless radiation. A few short years ago, I was no different from any of you sitting up there today. The medical community is simply not up to speed on this yet. More so, they are looking at the human body from the lens of their specialty. However, this is a whole body system condition. With the careless rollout of millions of cell towers and 5G small cells impacting our village, I'm showing I have 47 seconds left.
No, you're 3 minutes, and if you're welcome to submit the rest of your written testimony, and we will take it. We thank you for your time.
Okay, thank you.
Thank you. At this time, I'm going to pivot back to Xin-Yi Lau from the Newton Health and Human Services Department. Welcome.
Of the Joint Committee on Public Health. My name is Xin-Yi Lau. I'm a Boston resident, and for the last 7 years, I've worked for the Newton Health and Human Services Department. I started there as the public health nurse, and I currently serve as the Director of Public Health Services. I support H2204 S1334, also known as the SAFE 2.0 Act. It may surprise you that someone who works in a community as well-resourced as Newton is here speaking in favor of this bill. However, even a House department as well-resourced as ours, that's full of very hardworking professional staff, is unable to provide all of the mandated and foundational public health services that our residents need and deserve. Our city has one public health nurse, and during COVID, that public health nurse was me. So while I was surrounded by an incredible team who all pivoted to respond to the pandemic, this means that there was one nurse dedicated to case investigation, contact tracing, cluster surveillance, vaccine administration, test distribution, staying current on the latest science and CDC DPH guidance, data analysis, and providing much needed comfort and advice for almost 90,000 residents and hundreds of businesses, schools, daycares, and community-based organizations. And this was all on top of my continuing to do my regular duties, such as routine communicable disease surveillance, licensing summer camps, and planning flu vaccine clinics. During COVID, I discovered a new emotion, which I have named cromedy, or the feeling of wanting to cry and vomit at the same time. It's a physical feeling of despair, defeat, and exhaustion deep within your core. This is a feeling I had when I watched new cases come in 5, 10, 15, or even 50 at a time, knowing that each case could require hours to answer questions, provide reassurance, and do follow up with close contacts, and that each case was a human being with their own fears and anxieties around what testing positive for this new disease meant for them. This was the feeling I had when a woman yelled at me on the phone for 30 minutes, accusing me of cruelty because I couldn't vaccinate her because she wasn't eligible yet. This was the feeling I had every time I made a case investigation call and a family member picked up the phone and told me the individual had died from COVID. The only thing that kept me going through all of the tears, long hours, and sleepless nights was the incredible team I work with. Had it not been for them, I know I would have left the public health workforce, as many of my local health colleagues from across the state did. The Massachusetts local public health system is broken. It was broken before COVID and has gotten worse since COVID, with the workforce leaving in droves due to burnout, harassment during the pandemic, and lack of support. SAFE 2.0 will help repair the system by increasing capacity, improving quality, and most importantly, increasing equity by ensuring every resident has access to essential public health services no matter where they live. Please, for the health of Massachusetts residents and the sanity of the Massachusetts public health workforce, please give this bill a favorable report without delay. Thank you for your time.
Pivot to Amy Judd. Okay. Oh, Amy, are you here? Welcome. You're on mute.
How do I
There you go.
Oh, okay. Thank you. All right, let me just get my statement up. Thank you very much for having me. I'm Amy Judd from Lenox, and I'm here in support of House Bill 2158 to register EMS in a database and to educate healthcare providers and the public about this condition. As you may be aware, the United States National Council on Disabilities Health Equity Framework for people with disabilities embraces all categories, which includes electromagnetic sensitivity. Page 10, subcomponent 6 states that a high EMF and non-ionizing radiation environment may trigger disabling and life-threatening cardiac, respiratory, neurological, or other adverse reactions and requires administrative action through the U.S. Department of Health and Human Services Office of Civil Rights. This policy framework goes on to say further research should be conducted by our federal agencies, such as the FDA, HIN, HHA, and HUD. Yet there has been no funding to do this work because there's been no data driving it. You have the power to change that by registering EMS in a database so that those numbers can start to inform health policy decisions. The mission of the Office of Civil Rights is to enhance the health and well-being of all Americans, yet the victims with EMS time after time are left out. I have heard the EMS victims in Pittsfield literally beg for assistance and care for over 1,000 days, even with a recognized medical diagnosis of harm. They testify week after week of the profound impact this condition has on their health and their lives. Just as bad as being sick is the fact that those with EMS testify they feel invisible. These are our neighbors, our Vietnam vets, seniors, and children. They are worthy of being recorded and counted. When the ADA has recognized this for over 21 years, but we cannot provide EMS sufferers with the dignity of simply being documented, it is devastating. Please make account of these people by establishing an EMS disease registry. A component of this is making a committee to advise and assist in the development and implementation of the registry. You can put a team of experts together to figure this out. I am also asking you to support the education component of this bill so that everyone, whether a doctor, school nurse, or Board of Health volunteer, has educational materials for the public and for those persons diagnosed with EMS. People with EMS should not be told when they call their health department that their symptoms and condition don't get documented anywhere, especially when we see clusters of illness as in Pittsfield and Centerville. We need to know numbers. It's time you count these people and give them a voice. Please vote yes on this bill because you believe disability rights, equity, and inclusion is for all people in the Commonwealth, not just for some. I thank you so much.
Thank you for your testimony. At this time, I'm going to welcome up here Cheryl Bartlett from the Greater New Bedford Community Health Center. Welcome.
Good afternoon, Chairman Sear, Chairwoman Decker, honorable committee members. Thank you for this opportunity to speak today in favor of SAFE 2.0. My name is Cheryl Bartlett. I'm a registered nurse and I'm the CEO of the Greater New Bedford Community Health Center. Prior to that, I served as the Commissioner of the Department of Public Health under Governor Patrick, the first and only nurse to serve in that capacity. I've also served as a select woman on Nantucket, where we were able to create a comprehensive public health department and implement comprehensive public health services. As Commissioner of the Department of Health, I saw firsthand by traveling around the state to many cities and towns, the disparities in local public health departments. Many communities do not have trained public health professionals or the resources to meet the minimum public health standards that we know provide safe community sanitation, communicable disease control, and public health nursing. The impact of COVID pandemic magnified these disparities. I also saw this firsthand as the CEO of a large community health center serving diverse populations impacted significantly with higher rates of morbidity and mortality. We at the health center scrambled to step up and support the health department, providing COVID testing, contact tracing, and vaccinations, along with public health education and awareness they didn't have the capacity to provide, all while maintaining our core services as a primary care provider and treating many patients who were suffering from COVID. Massachusetts has one of the most fragmented approaches to public health, with over 351 health departments, many of them inadequately staffed or funded. SAFE 2.0 is essential to prepare Massachusetts for the next pandemic, which we know is coming. It's only a matter of time in this global world in which we live today. I thank you for your time and commitment to public health in Massachusetts. SAFE 2.0 is critical for public health equity now. Thank you.
Thank you for your time.
Thank you. See.
At this time, I'm going to call up Dr. Lori Deutsch or Dutch. Okay. Scott McCollough. Theodora Scarato.
I was trying to get on. I'm
Okay,
Scott
Scott, welcome.
McCollough. Thank you very much. I'm going to give you back much of your time. I'm a lawyer and I'm from Texas, but I happen to be the one that's representing the Pittsfield residents that you've been hearing so much about. So although I will not take up all of my time, please recognize that despite the fact that I'm not a citizen of your state, I have many contacts here, including clients. You've heard a lot of riveting stories about people's testimony, and sometimes you can get overwhelmed by that. What should be even more overwhelming is the potential numbers that are involved in this particular condition. You heard a 3% number earlier from a Swedish study. If you apply that to the Massachusetts population, that's 200,000 people that may have this affliction, that are living a terrible life, isolated from society. Here's some other numbers. A different study from a few years ago indicated that up to 30% of the population experiences mild symptoms. Applied to Massachusetts, that's a little over 2 million people in your Commonwealth. 5% may have moderate symptoms. That's 350,000 people in your Commonwealth. There are some who are so afflicted that they just cannot do anything. It's beyond severe symptoms. That's about 0.65%. That's almost 5,000 people in your Commonwealth. So it's pretty clear that you may have tens or hundreds of thousands in your Commonwealth that are suffering from EMS in at least some form. And many of them will ultimately experience these severe symptoms you've heard. This is indeed a disease under the definition in the Massachusetts Code of Regulations. It must be recognized, affirmed, registered, and tracked. Any other significant malady with this kind of prevalence would be. Indeed, you've been taking up other bills about other illnesses, and the numbers are even smaller for many of those than it is for this. Your health authorities need to know what's happening to your citizens in this regard. Professionals and policymakers must get an idea of its prevalence and the relative level of existing suffering. This bill is a starting point for recognition, acceptance, and enumeration. I ask you to bring EMS and those who suffer out of the shadows and give them some hope. Thank you.
Thank you. At this time, I welcome Theodora Scarato. Are you with us, Theodora? Okay. Janet Fitzgerald, I told you would get to you. Welcome. You're muted.
Yeah, got it. Thank you. Thank you so much. My name is Janet Fitzgerald, and I live now in Rowley, Massachusetts. And I agree with all the testimony you have heard from those asking you to support House Bill 2158 to recognize, document, and as Scott McCollough said, to register EMS as a disease and establishing the Massachusetts EMS Registry, and to be included, of course, in MAVEN, and to help educate healthcare practitioners and patients and government decision makers like yourselves who represent us. I cannot see any reason why not to do this, because so many of us are suffering, like myself. The science is real, independent, peer-reviewed science. And because more and more people, as Mr. McCollough pointed out, are suffering EMS. I learned the hard way I was EMS. I suppose most EMS patients do until they find the experts who have studied the real science that helps guide us to learn how to modify our lives if possible. And to teach us about scientific measuring tools like this, an RF meter, that helped me know where the radiation sources were so I could modify them. It made a difference. I learned, for example, I can't be in a Bluetooth car. I get horrible headaches. I get, it's like the equivalent of car sick, but only in a Bluetooth car. So we bought an old car, headaches gone. It was fun. I learned I can't live in a condo because the Wi-Fi radiation coming from both sides ended up giving me terrible migraines, uncontrollable shakiness. My hands were shaking. My body was shaking. I drove to a doctor that way, and I got treatment finally. It took me a long time, however, to find that doctor who understood what EMS was. But it did help when I finally got it. I just wish other doctors I saw knew too. It would have saved me a lot of time and suffering, and trying to explain in my appointments to these doctors what EMS is. And again, I bring out hard science to show them. But that should not be my job. There is, by the way, really important to know, an EMF medical conference still available on Vimeo for $39. It's nothing, right? And health practitioners like myself, I am one, by the way, I'm a speech pathologist, can earn 24 CEU credits. But our doctors don't know about this. I so wish they did. This bill will help. After we moved from our condo to a single family home in lovely Rowley and made some modifications, it made a huge difference. And so I feel for all the people who don't have that choice. If we believe in science, however, we need to listen to the independent scientists all around the world who have studied this growing disorder. Thank you. I hope you will pass this bill, because that is your primary job, to protect us.
Thank you.
Thank you. Thank you.
Thanks for hanging in there.
Thank you very much.
All right. Jean Lemieux.
Yes.
Welcome, Jean.
Thank you. My name is Jean Lemieux, and I am the president. Can you hear me all right?
We can hear you.
Okay. I am president of the Massachusetts Association for the Chemically Injured, a volunteer nonprofit statewide support, education, and referral organization for people with multiple chemical sensitivity. And I am providing testimony in support of H 2158 on behalf of our members. I deal with real life experience as a chemically sensitive individual myself, and in my role in talking with our members and other persons who contact our organization. Today, in oral and written testimony, you are continuing to hear from individuals whose lives have been drastically changed, real life experience. H 2158 raises the issue that members of the population have developed a condition called electromagnetic sensitivity, a medical condition relating to exposure to EMFs and RF in the environment, and to recognize that this medical condition is presently occurring in the Commonwealth. We support the inclusive scope of this bill and believe it is fundamental and important to address this growing health issue. Action needs to be taken now. The number of individuals who experience such reactions to various EMF, RF in the environment has grown, and the potential to increase in prevalence given the vast amount of EMFs, RF in today's environment is a reality. Macy, was founded in 1994, and I have witnessed this within our organization's members and in the public context to us. Many people who suffer from multiple chemical sensitivities are concomitantly vulnerable to the effects of EMFs and RF. The combination of sensitivities is quite disabling, puts their ability to work and to live in their residences at greater risk. A population survey of hypersensitivity to electromagnetic fields in California found chemical sensitivity to be an important risk factor for hypersensitivity to EMFs. This observation is of significance because instituting a process, a registry, which will help track incidents and provide data, an advisory committee to help guide the process, the development of educational materials and diagnosis guidelines for identification of symptoms associated with EMS, and dissemination to the public and healthcare providers will lead to better management for those already experiencing health effects and enhanced measures to prevention. Please note that it is essential to have professional persons, physicians and researchers on the advisory committee who have experience with EMS, as well as the inclusion of EMS patient representatives.
Thank you.
Was a
Thank
member
you.
of MCS advisory.
Thank you for your testimony, Ms. Lemieux. If
Thank
you'd
you.
like to submit for more testimony, please do in writing.
I have tried. I'm going to try again after the hearing.
Okay, if you're having trouble, my staff will also reach out to you. We have your contact
Okay,
information.
thank you. It got rejected. It came back. It said.
No, we'll reach out to you then.
Thank you.
Okay, thank you. Aleister Mraz. Okay, Irene Polansky.
Can you hear me?
Not, go ahead. Is that Irene?
Yes.
Okay, go ahead.
Let me just adjust one thing. Is that better?
Oh, we can hear you. You're fine.
Okay, hold on one second. Okay, this is a new software for me. Okay. Okay, here we go. Greetings from Maryland. Wireless devices and infrastructure are etiological sources of harm that trigger undeniable and causal relationships to clinical consequences known as EMS. It's vital to talk about the resulting symptoms, the negatively life-altering impacts, plus discrimination and exclusion from society in regard to H2158. My own functional integrative doctor of 22 years who successfully testified about my non-EMS disabilities in 2005 diagnosed me with exposure to non-ionizing radiation in 2018. I initially presented with a BP that skyrocketed 74 points above my very hypotensive norm that put me in the ER. RX boomerangs and trauma and home-based findings from 2 wired devices defaulted to Wi-Fi unbeknownst to me prior are too numerous to explain. My symptoms also correlated with cell tower radiation in a retail area that I had frequented and have never returned to since. EKGs followed, and despite hydration and other IVs intended to alleviate symptoms, lab results revealed that my dehydration went up versus down amidst the doctor's Wi-Fi and other devices. Fast forward, and that environment has been worsened with an upgrade to 5 gigahertz Wi-Fi last June. I haven't returned for an in-office visit because while it's true that staff wouldn't be able to function without it, there's alternatively no talk of shielding even one exam room. This physician's clinical knowledge about my entire disability history is incomparable, absent his failure to accommodate EMS. Bill H2158 requires the EMS education of healthcare providers that's long overdue and sorely needed. Last week, I asked 2 sonographers to turn off their cell phones during my ultrasounds. In the waiting room, a floor sign promoted safety, while in contrast, a table sign next to it promoted free Wi-Fi. On Tuesday, I kindly informed a specialty doctor of the RF radiation that I metered in her reception area, made worse by upfront staff on wireless headsets working on wireless computers while also wearing trendy wireless watches. It's a simple concept that you can't get and stay well in the same environment in which you got ill. Yet those who should be medical leaders regarding prevalent wireless radiation dangers are instead inflicting their vulnerable patients and themselves with same. A doctor's office should be a safe haven, not a Class 2B carcinogenic danger zone. This bill would alert the relief and remedy needed from such electrosmog assaults and grant provider education for accommodation and diagnosis of EMS patients. The bottom line is that nobody testifying today will tell you that the profoundly deleterious RF effects we forced to endure in today's wireless world should go without being recorded and monitored and tracked as a verifiable illness and disease for recognizable impact and MAVEN for recognizable impact on clusters of people. You are being asked to make our invisible data visible and to stand up and be counted for H2158 so that we too can be affirmed as counted. We are EMS victims who suffer from irrefutable harms. Let Maven be that mandatory place to register those very harms and pave the way for 49 other states to do the same. Thank you.
Thank you. Thank you. Okay, this time I'm going to call up Bill Murphy from the Framingham Department of Public Health.
Thank you. Chair Decker, Chair Sear, honorable members of the Joint Committee of Public Health. Thank you for the opportunity to speak with you today. My name is Bill Murphy, and I'm here today in support of H2204 S1334, also known as SAFE 2.0 Act. I'm currently serve as a new health director for the city of Framingham, and I'm the current president of the Massachusetts Environmental Health Association, representing over 350 public and environmental health professionals. I was a former health director in Sudbury. Currently in Massachusetts, there is no uniform minimum public health standards for cities and towns, including providing qualified environmental health professionals. Services provided by health departments are highly variable and are often inequitable. Many health districts do not have any certified professionals to rely on. I have a unique perspective of suburban and urban local public health systems and lead an organization that educates and trains the municipal public health workforce. My department in Framingham is an organization of 18 professionals and support staff. There are 9 vacant positions. There is no public health nurse or community health workers to support vaccinations or address vast health disparities. My health inspection staff is down 3 as demand for food, pool, beach, housing, body art, camp, environmental protection inspections continue to increase. Qualified, trained professionals are the most critical part of any health department's capacity to meet mandates and ensure compliance. The majority of Framingham is located in an environmental justice area. Public health responses to EJ issues cities face, such as homelessness, substance abuse, and housing and food insecurity, can only be successfully addressed with trained professionals. There is simply not enough of them now or will be in the near future. The state has begun efforts to build and increase capacity of local health with the local health workforce before we've even begun to replace the professionals lost to attrition and pandemic-related burnout and resignations. Yet daily, we are faced with a new set of issues that need immediate attention. Last month, we received a report that Lake Cotuit had PFAS detected in fish. Messaging in multiple languages was required. Meetings were held to increase efforts to minimize risk of harmful algae blooms in recreational water bodies that our vulnerable populations use frequently. Fielded calls from stakeholders preparing for a new wave of refugees to the area. Investigated unusual unlinked reports of Yersiniosis and Shigella in 1 week. Participated in internal meetings to assess new cannabis dispensaries and applications. These are weekly issues that we address at 50% capacity. The SAFE 2.0 Act will begin to address many of these current deficiencies within local public health, in addition to credentialing and standardizing. In previous testimony, I made an analogy of the pandemic related to
Mr. Murphy, I'm going to ask you to wrap up. That was your thing.
I'm grateful for the committee for your support of this legislation last session and urge you to support SAFE 2.0 with a swift favorable report.
Thank you. Thank you for your time. At this time, I'm going to call Helen Walker. Helen, are you on our teams?
Hear me?
Helen Walker.
Hi, can you hear me?
I can hear you, Helen. Welcome.
Thank you very much. Thank you. I'm from Cambridge. Thank you for the opportunity to testify in support of House Bill 2158, recognizing electromagnetic sensitivity as a disease dangerous to the public health, including it in Maven, and establishing the Massachusetts EMS Registry. My first reaction to the notice of hearing was to count the number of my colleagues with serious EMS. Within a couple of minutes, I had listed 15. By serious, I mean the full range, from having to avoid certain rooms of one's home because of EMS exposure in those rooms, or having to move out of one's home entirely, or even to becoming totally disabled and requiring assistance with activities of daily living. People with electromagnetic sensitivity have great difficulty accessing healthcare and public services because they cannot tolerate the exposures to electromagnetic radiation that are now considered normal in daily life. The U.S. Access Board recognizes that electromagnetic sensitivity may be considered a disability under the ADA if it causes severe impairment. Social Security administrative law judges have found electromagnetic sensitivity to be a severe impairment, limiting the ability to perform gainful work activities. We need to highlight the prevalence of this condition so that we can move on to providing reasonable accommodations and meaningful medical assistance. Think back to the first year of the pandemic, when long COVID was treated with suspicion. But when the extent of the problem became obvious, Senator Markey and others stepped up and called for research funding and studies of clinical trials. This included review of the valuable information that already existed because it had been gathered through studies of related conditions like chronic fatigue syndrome. We will need similar funding for research into a way forward for those who suffer from EMS. We can't expect a proportion of our population to deal with their severe medical problem by continually moving their households to more and more remote locations off the grid. Important research is being done in France and Italy and Sweden and Canada, just to name a few of the countries involved. We in Massachusetts need to better define the problem so that we can get on with our own research. But first we need to understand the prevalence. Passing House Bill 2158 is the first step. I want to thank you for hearing my testimony, and I want to thank you for all the important work I see today that you're doing with this committee.
Thank you, Helen, and thank you for all of your communications to my office from Cambridge. It's nice to hear your voice.
Thank you, Marcia.
At this time, I would like to welcome Jonathan Mirin.
Thank you, Madam Chairwoman, and thank you, senators and representatives, for hearing today's testimony about all the bills and including H2158, an act recognizing EMS as a disease dangerous to public health. My connection is that in 2010, my wife and I, we were on a touring theater company. We were in Boston. Our son was 9 months old at the time, and I got a call from the theater that my wife was at Faulkner Hospital, and I went over there. She was diagnosed with a possible virus. She was dehydrated from vomiting, etc., and she was dizzy. And we left the hospital, went back to our home in Western Massachusetts. We live in Charlemont, and she was still dizzy, and she remained dizzy for about 2 years as we went from doctor to doctor trying to get to the root of her dizziness, which then progressed to symptoms like spasms, difficulty sleeping, difficulty thinking, difficulty coordinating her limbs, to the point where she had difficulty leaving the house and couldn't drive anymore, et cetera, et cetera. Finally, after 2 years of this merry-go-round, we found a practitioner who was actually electromagnetically sensitive herself. If we hadn't found that practitioner, which was just by chance, we could still be in that situation. Frankly, I'm not even sure she would still be with us if she had to endure another 8 to 12 years of that experience. So like the other people that you've heard from today, we made some changes and she began to get better. Now we've created a grassroots organization called Hilltown Health out here, where we advocate for people with electromagnetic sensitivity, and we work with local towns to create appropriately cited cell tower bylaws. But in the meantime, on my little Excel spreadsheet here on my laptop, I have, like Helen, about 15 people who are on the severe end just in our little corner of Western Mass, and that's just the 15 people who have contacted me who I know. I know there are dozens more who have not contacted me. These people are cut off, generally speaking, from the internet, which you and I take for granted. And so, I should not be doing this on my laptop. We really need Maven to start tracking this. We created a documentary called Canary in a Gold Mine, which had people from all over the world and all over Massachusetts tune in. I'm happy to send you a link, each of you a link for to watch Canary in a Gold Mine, which is basically about our story. And essentially, Sweden's figured this out. Austria's figured this out. They have accommodation for people like this. It's really a question of what kind of society we want to be. Is it a society where we take people who are economically inconvenient and sort of try to ignore them? Or do we say, well, you know what, this is real and we see you. And in fact, we're going to benefit all the tens of thousands of people who are at moderate stage symptoms by getting this out there and preventing them from descending into the sort of hellish place that my wife and so many others have experienced. So it's an economically advantageous bill for Massachusetts. It's a preventive bill, and I really thank you for your time and your consideration.
Thank you for your time. At this time, we have called through our list of people who have signed up to testify, either virtually on Teams or here in person. I want to thank everyone who has taken the time to share their thoughts and concerns and testimony. If you have more to say or think that you please feel free to submit all written testimony here in public. Submit all written testimony, and we will, as chairs and committee staff and members of the committee, read that. I want to thank my co-chairs here, our first hearing together. This term. We had the privilege of chairing a committee together 2 years ago. Also, I know my vice chair had to step up. I wanted to thank my vice chair, Sally Herons, and to members of the committee who stayed here. We have a lot of new members who are new to the legislature. Thank you guys for being here and for sticking through it. Listening to this testimony is important. Thank you to LIS. Thank you to my chief of staff, Kathleen Hornby. Ramla, who thank you for your committee work, along with Marissa and Tane, who are in the background as well. And I look forward to our next hearing. Are there any questions or comments from committee members this time? Okay, hearing none, we are officially adjourned. Oh, Scott, thank you.